Good morning, everybody, and welcome to Mesothelioma UK's Patient and Carer Event 2021. We're delighted to have all of you join us today for what we hope will be an interesting and interactive day. I just want to say a special thanks to Bristol Myers Squibb. This event has been made possible thanks to their generous donation. As I say, we hope the day will be interactive, and we would encourage you all to pose questions to everyone who's speaking today using the chat function on Zoom. We will have two panel sessions where we can put those questions to them. For those of you who don't know me, my name is Carolyn McRae and I'm a Mesothelioma UK clinical nurse specialist. I'm based in Glasgow and cover the west of Scotland. I'm also the CNS team leader for Scotland, and I'm delighted to be here today with my colleague Anne Moylan, who will introduce herself and talk you through today's agenda.
Thank you, Carolyn. My name's Anne Moylan. I'm the Mesothelioma UK nurse based in Portsmouth and covering the Wessex region, so quite a big area on the south coast. We have a really interesting and interactive programme for you today, including some breakout rooms later on, just before lunchtime. We will tell you how to access those rooms a little bit nearer the time. We appreciate that sometimes PowerPoint can be difficult to read on Zoom calls, and the presentations and the slides will be available to you after the day. So I'm going to hand back to Carolyn to introduce our first speaker of the day.
Thank you. So to discuss an overview into the coroner's inquest, we have Mr. Ivan Cartwright. Ivan Cartwright is the area coroner for Leicester City and South Leicestershire, where Professor Catherine Mason is the senior coroner. Ivan took up the role on the 1st of June 2020, having worked as a part-time assistant coroner in Nottingham between 2013 and 2020. Prior to June 2020, he also practiced as a barrister for 25 years, working in a variety of legal fields, first in Liverpool and then in Nottingham. He is married to a GP and has two young sons. Thank you, Ivan, for your presentation today.
Good morning, everyone. My name is Ivan Cartwright. I'm the area coroner for Leicester City and South Leicestershire. I'm going to speak to you today a little about the coroner's inquest and what to expect, what happens, what the coroner's task is, and how an inquest might progress if one is required in relation to the reporting of a death as a result of a specific disease, and more specifically mesothelioma. As I said, I'm Ivan Cartwright. Very briefly, in terms of background, I was a practicing barrister in Nottingham and before that in Liverpool between 1995 and 2020. And from July 2013, I also worked as a part-time coroner, called an assistant coroner, in Nottingham City. After that, and more recently, from the 1st of June 2020, so really a couple of months after the COVID pandemic lockdown commenced, I've worked full-time as a full-time coroner or area coroner in Leicester. An area coroner is really just the name given for the senior coroner's deputy. So I work with and under the senior coroner for Leicester City and South Leicestershire, being Professor Mason. Just a very little about coroners. Coroners are independent judicial officers who investigate deaths that are reported to them. That means that although there is a senior coroner for each of around 90 geographical areas in England and Wales, and some of those senior coroners work with area coroners and assistant coroners, the resources, the staff, the premises are almost always provided by the local authority, including court premises. A coroner, however, is independent of the local authority and answerable only to the chief coroner as well as other judicial regulatory bodies. That is, the coroner is not an employee of the local authority. Let me talk a little about what happens immediately after a loved one passes away from an asbestos-related disease such as mesothelioma. It doesn't need me to tell people and to explain that it can be a very difficult, confusing and distressing time for those who are left behind. If there is a suggestion or a possibility that the death has been caused by an industrial disease, such as an asbestos-related disease like mesothelioma, the death must be reported to the coroner. Now, there are a number of reasons and a list of which deaths must be reported to the coroner, but I'm not going to go through them all because certain deaths are not relevant to what I'm going to talk about this morning and what you perhaps would like to hear. Certain deaths, though, that are caused by industrial diseases or work-related deaths are always reported to the coroner, and it is usual that an inquest will always follow such a report of a death to the coroner. After the death is reported, and that usually happens within days of the person passing away, the coroner will open an investigation and will proceed to list an inquest into the death, specifically looking at a number of questions, which I'll come to shortly. I hope that this short introduction will help somewhat to relieve any anxiety that anyone might have about the inquest process, and also help a little about what to expect when the coroner's office, through the coroner's officers, get in touch with the bereaved family following a death. Now, some common questions which I hope are of assistance in answering. Firstly, will your loved one have to have a post-mortem as part of the inquest process or the investigation? Let me try and assist with that first. If doubt about the medical cause of death, the coroner will usually request a post-mortem examination to be carried out. The coroner will consider all relevant factors, including the family's wishes, as to whether they will order a post-mortem or not. However, the final decision is the coroner's alone, and they need to be mindful of their wider legal duties and responsibilities. That said, in the majority of cases in my experience, there is no or little doubt about the cause of death, as a hospital doctor or sometimes a general practitioner has identified the cause of death and has communicated that to the coroner's office. Now, the exact purpose of a post-mortem examination will depend on what type of disease is suspected. During the illness of the bereaved, and especially during the later stages of the illness, it is often not deemed in the patient's best interest to be put through an invasive biopsy procedure or surgical procedure. Therefore, sometimes a formal diagnosis is postponed until lung tissue samples can be taken, and that's taken, of course, at the time of the post-mortem examination. Mesothelioma can sometimes be difficult to diagnose as its appearances can differ, and it may be confused with other similar conditions. I'm not going to go into the medical or scientific aspects of that particular exercise and that diagnosis, simply because I'm a lawyer, not a physician or a general practitioner or a trained medic, and it is perhaps for others, including specialist nurses, to assist with that. But for that reason, sometimes the diagnosis can only be obtained through a post-mortem examination. That usually means that where lung tissue samples are taken for histological testing, the testing of the tissues in order for the disease. All that, the coroner will look for what material is already available. That might include GP records or summaries of records, hospital clinic letters or discharge letters, results of biopsies that have taken place during the life of the bereaved, specifically looking at trying to ascertain a diagnosis, and also reviews by pathologists of those biopsies which have taken place in life, and as or more importantly, what the family or those closest to the patient know about the patient's occupational history, the diagnosis, and the progression of the disease. And I stress that because, of course, it's the families and or the carers and next of kin's assistants which really assist the coroner when they're looking at investigation and looking at type of inquest is required. In addition, and if it is required, the deceased general practitioner or treating physician, that is the hospital clinician, might be asked to provide a short report regarding the person's health in the months and weeks leading up to their passing, including confirmation of any diagnosis. Now, what happens during an inquest investigation? Well, as well as those medical investigations mentioned, and as well as those investigations which include the collecting together of reports, the coroner will also investigate how and when the deceased may have been exposed to asbestos. A first-hand witness statement taken in life, such as by a solicitor as part of the claim, is often the best form of evidence to show asbestos exposure in detail. That might be because a solicitor, as part of a claim, has looked at a comprehensive detail and comprehensive history of the occupation and employment of the deceased. But if that is not available, either because it hasn't been done, or because a claim hasn't been started or intimated, or a claim is not envisaged, then the family, next of kin or carers will also be, or can also be, very helpful to provide the coroner with that kind of information to help the coroner with the investigation. Now, to help further, that might simply be a sheet of paper setting out, or an email setting out what the family's belief is about where their loved one worked, what type of work he or she was involved in, and how, in their belief, that person was exposed to asbestos. Now, once a coroner is satisfied that they have all the relevant information, the coroner will formally list a date for inquest. Another question that's key: how long does an inquest take? How long does the whole investigation and process take? Well, if a post-mortem examination is not required, and I should say in my experience, in the majority of cases, a post-mortem examination is not required. If it is not required and the coroner has sufficient information concerning the cause of death and any diagnosis of mesothelioma, the inquest can be conducted within a few weeks. That is, within a period of 14 to 28 or 35 days. If a post-mortem is required, an inquest can be listed for several months into the future, or longer if further specialist histological testing or medical evidence is required. Now, my own experience of being a coroner as a part-time coroner since 2013, and as a full-time coroner in the last 15 months, is that it is unusual for an inquest to take place more than 3 to 6 months after a person's death from mesothelioma. But I fully understand that different areas have different processes and sometimes take longer. I'm also fully aware that in the post-COVID pandemic period, there is a backlog of cases in a lot of coroner areas, and the recovery period means that some inquests are taking longer than others. But in my area, Leicester City and South Leicestershire, we try as well as we possibly can to ensure that mesothelioma inquests are heard within weeks or a couple of 2 to 3 months from the date of the deceased's passing. At all stages in any event through the investigation, families or carers can expect the coroner's office, through its officers who assist and maintain with the bereaved family, a next of kin or carers on a regular basis, to vital and important and updated information on the progression of the investigation and the likely date of completion. A completion is the date when the inquest occurs. Now, when, where, and how does an inquest take place? The coroner's officer will provide notice to the deceased family and the next of kin or carer of the time and date of the inquest and ask whether they wish to attend. All information that is to be relied upon by the coroner will be supplied to the family or their legal representatives, if they have any, in good time prior to the inquest hearing. I've mentioned legal representatives, solicitors. It's not necessary or vital for a family to be represented, but they may wish to be. The family do not have to attend the inquest, but they should always be given the option to attend the inquest remotely, that is online, or in person. In the majority of cases, evidence will not be heard formally in court from witnesses because it won't be necessary. Rather, the coroner will read and consider the relevant evidence that's already been shared with the family and reach a conclusion on the basis of that evidence as shared with the family, When opening an inquest and when completing an inquest, the coroner asks him or herself 4 main questions. Who was the deceased? When and where did the deceased die? What was the medical cause of death? And how did the deceased come by their death? As you can probably understand, and for mesothelioma inquests, questions 1 and 2 are relatively simple to answer usually, and questions 3 and 4 may be the more difficult questions to answer. To answer question 3, the coroner will review the reports or statements provided by the deceased treating clinician or the general practitioner, along with the post-mortem report, if one is available, to determine whether or not a diagnosis of an asbestos-related condition can be supported. When I say supported, a coroner looks at whether it can be supported on the balance of probabilities. That is, it is more likely than not that an asbestos-related condition or exposure to asbestos caused the condition which led to the deceased's death. A coroner does not have to be sure beyond a reasonable doubt. Following on from this, and to answer the final question, how did the deceased come by their death, the coroner will evaluate all of the information provided, including any information provided from the legal representatives, if they've been involved, and ask him or herself what role asbestos exposure played in causing the deceased's diagnosis and subsequent death. If the coroner is of the belief or knowledge on the evidence that's been provided and shared with the family that asbestos caused the condition which led to death, a finding of death by industrial disease will be made, and the conclusion will be industrial disease if all of those factors and criteria is met. That means at the completion of the inquest, when the coroner has either heard or read the evidence in front of the family if they want to attend, or without the family present if they do not wish to attend, the coroner will complete something called a record of inquest, which details all the information to be available and provided for the purposes of registering the death, but will also answer the question how the deceased came by his or her death and give a conclusion. The answer to the question how might simply be the date of diagnosis, the main information about asbestos exposure, and the date of death and the place of death, be it at a hospice, at home, or at hospital, for example. The conclusion will simply be industrial disease if the coroner is of the view that, for example, asbestos exposure has caused the mesothelioma from which the patient has died. Now, briefly, what happens after an inquest? Although the coroner's role is not to apportion culpability or guilt into any party, that is, it is not the coroner's task or role. In fact, the coroner is not permitted to find anyone to blame. But that to one side, a finding of death caused by an industrial disease can provide a family with some level of closure, answer some of their questions in relation to what might have happened with the bereaved years and years ago, sometimes when they worked in a setting where exposure to asbestos occurred. So it is hoped, certainly by the coroner's team and officer and by the coroner, that some level of closure might be given. As importantly, finding of an industrial disease conclusion may well be supportive in any legal claim, although it's important to say that the coroner cannot provide legal advice, and that would be for a bereaved person or their family's legal representative. Once a cause of death has been finalised and the conclusion reached and the record of inquest completed, that record of inquest can be provided or will be provided to the family, to their legal representatives, and to any other interested person. For example, excuse me. For example, it may also be provided either by the solicitor or by the coroner's officer direct to any insurance company if they seek it or need it in order to deal with a claim for life insurance. But once the cause of death has been finalised and the conclusion completed, the family or next of kin can obtain final death certificates and formally register the death with the local register office. Certainly in my area, the registry office is in the same building, the town hall in Leicester, as the coroner's office and coroner's officers are working. So it is hoped that that is a relatively simple process. Once that has been completed, both the coroners and the registration services have completed their role, and it is certainly hoped that the bereaved family, next of kin and carers can then move on and proceed in whichever way they wish. I hope that very brief and whistle-stop tour to what the coroner does, what the coroner's task is, and what the coroner's office and coroner's officers should do to assist those who are dealing with a bereavement is helpful. Thank you for listening, and I hope it has been of some assistance to you. Thank you.
Thank you, Nigel, for that first session for today. If you have any questions, would you put them in the chat box feature on the meeting? At the end of the session, we're going to bring the speakers back, and you'll be able to we'll be able to ask the questions on your behalf, and they'll answer them for you. For our second session this morning, I'd like to welcome Natalie Craven. Natalie is a project manager at Breathe Arts Health Research, managing a number of both participatory and live performing arts programmes for staff and patients at Guy's and St Thomas's Foundation Trust. These programmes aim to boost wellbeing and create a positive impact on the healthcare environment. And Natalie's colleague, Edmund, is going to be doing a practical session in one of the breakout rooms just before lunch. Welcome, Natalie.
Good morning, everyone. It's a pleasure to be here. Thank you for that introduction. Yes, my name is Natalie Craven and I'm Project Manager at Breathe Arts Health Research. And I'd like to thank Liz Darlison, who invited us here to speak today. So I'm here today to talk to you about one of the programmes that I run called Breathe Sing for Lung Health. Firstly, though, a little bit more about Breathe. We are a not-for-profit social enterprise with a team of 12, which celebrates its 10th anniversary next year. We design and deliver creative programmes underpinned by scientific research to improve health and wellbeing. Our innovative and artistic approach to transforming healthcare experiences offer those we work with a sense of empowerment, hope, and creative fulfilment when they need it most. Our work is designed with artists, scientists, healthcare professionals, and patients to meet specific clinical and wellbeing needs. We deliver a diverse range of evidence-based participatory programmes and live performance events across a range of art forms, and we believe in a collaborative and creative approach to healthcare, working closely with a group of artists, musicians, dance practitioners, poets, and even magicians to deliver our work. We also believe in artistic excellence and the quality of the creative intervention. All our freelancers are paid professionals and they're experts in what they do and are paid fairly for their time and their work. We receive core funding from Guy's and St Thomas charity to carry out this work, but as a social enterprise, we're also able to fundraise as well. I'm just switching over my slides, which I don't think is working. So my role at Breathe, there we are. My role at Breathe is to manage the work we deliver to staff and patients at Guy's and St Thomas in London. And my colleagues look after our national programmes, of which these are just a few that we run across the UK. For some examples of the work at Guy's and St Thomas, we run a 10-week group dance physiotherapy class for older patients to improve their strength and balance, led by a dancer. We run a resident musician programme where a number of talented musicians visit wards, units and staff wellbeing areas to reduce stress and anxiety through uplifting live music. Again, these musicians are experts in performing in a healthcare setting, engaging with those they meet, adapting to the space they're in and selecting the appropriate music. So we have lots of stringed instruments, we have lots of harps, guitars, violins. We don't go in with a brass band causing chaos into a ward. NHS staff wellbeing has been a higher priority than ever in the last 18 months. And our staff wellbeing offer has always been a strand of our work, but has grown considerably during the pandemic to support staff. We run an NHS choir called Breathe Harmony, who released their first single last year, and have worked on a number of virtual performances during the pandemic, including appearance at the BBC VE Day celebrations last summer. In the past 18 months, we've also set up an online evening dance class for staff to switch off and forget about their day, and an online lunchtime drawing class called Creative Breaks, led by an artist, which is designed to fit into a lunch break, encouraging staff to take a break and switch off for 30 minutes. So these programmes were really born out of our conversations with staff who we work really closely with, and we heard that they weren't taking a break and they missed going to the gym and feeling like they had done something for themselves and exercise. So we really listened to the staff before we created a new programme. Over the last 18 months, with restrictions on our lives, we are all more aware of our own personal well-being and what can help us feel a sense of connection, feel inspired and feel cared for. Many people during this period of uncertainty have taken solace in the arts and creativity as an outlet for expression, maintaining a routine and discovering new skills and passions. We're encouraged by this greater awareness and understanding of personal well-being that we hope will continue to help the arts and health sector become more embedded in the NHS and patient care. And I'm just trying to switch my next slide, thank you. And now to what Breathe Sing for Lung Health is. Our Singing for Lung Health group was developed in partnership with Guy's and St Thomas Respiratory Team for lung and respiratory patients with conditions including IPF, COPD and interstitial lung disease. The programme aims to improve lung health and help manage symptoms of breathlessness through physical warm-ups that support participants with their posture, vocal exercises and group singing. Common symptoms that our participants live with are breathlessness, coughing fits, and finding everyday activities a challenge as they get out of breath. One of our group describes his breathlessness as if he's carrying a thick, heavy cloak around his shoulders. And this breathlessness can lead to a much less active lifestyle, which we know in turn can lead to further health problems. At Breathe Sing, we work with a number of talented vocal coaches specifically trained in singing for lung health, who are experts in breath control and vocal training for patients with breathing difficulties. We sing songs from around the world that are specially selected to challenge and stimulate physically as well as cognitively. Many of our songs also include long phrases that participants are challenged to sing in one long breath. There's also particular emphasis on lengthening the out breath and emptying out the lungs, and encouraging deeper breathing and the use of the diaphragm to prevent what clinicians refer to as stacking breaths, when lots of short breaths or in-breaths from the chest can contribute to a feeling of breathlessness. Really importantly, the group also provides a fun, safe, supportive community. Our singers have told us they feel less like patients and more like a group of friends that come together to sing. They even refer to themselves as not just a singing group, but a singing family. Everyone can sing, and in a Singing for Lung Health group, it doesn't matter how well you think you can sing. It doesn't matter if you need to stop partway through a song to cough. You are around people who understand and accept you. Participants tell us that singing together has been helpful in countering some of the stress and tension of living with their condition, and is something to look forward to in the week. The referrals process can vary, but patients are mostly referred to us directly through the lung clinic at the hospitals and by the lung nurses and their team. And we also promote directly to patients in waiting rooms and public areas, as we understand the importance of patients having a choice and to feel a sense of ownership over their care. Thank you. On to the benefits of Singing for Lung Health. So it's an arts and health initiative that started back in around 2007 at the Royal Brompton Hospital in London, when a member of their arts team observed a pulmonary rehab class and realised the natural connection between the exercises that were being taught to patients in the gym and the exercises that singers would use to warm up. Since that time, the initiative has received significant, albeit slightly sporadic, funding that has trained hundreds of Singing for Lung Health facilitators and has produced thousands of advocates from lung and respiratory patients who have benefited from the programme. And one of the key developments is that the British Lung Foundation has got behind this initiative as a way to support people with lung diseases. There are a number of physical, psychological and social benefits that have a positive impact on the quality of life for participants. So it improves their breath control, as I mentioned, and detracts from the breathlessness. It offers tools for self-management outside the group for posture, breath and anxiety. So these exercises that people can do when they're out and about and they feel that breathlessness coming on. And it specifically is tailored for respiratory conditions, unlike normal choirs. And again, the social participation reduces feelings of isolation in an enjoyable musical activity. I hope that many of you have heard the term social prescribing. Social prescribing enables GPs, nurses and other primary care professionals to refer people to a range of local non-clinical services to support their health and well-being. It seeks to address people's needs in a holistic way, and it also aims to support individuals to take greater control of their own health. So for instance, if you were to have a fall, a group physiotherapy dance class may be prescribed to you as part of your rehab. And other examples may include volunteering, arts activities, group learning, gardening, cooking, and a range of sports. Pre-pandemic, our group met at the South Bank Centre in London, and we were kindly hosted by their creative learning team. During COVID-19, we quickly adapted the delivery of Breathe Sing to virtual sessions on Zoom, as we knew the pressing need to support this vulnerable group. The online format has flourished as an accessible place that could be joined from home during lockdown and maintained that sense of connection and community to help combat isolation, especially for those living alone. Several of our group also joined from their hospital beds online, whilst particularly unwell, but not wanting to miss a session, which was amazing to see nurses around their bedsides. Group members who were shielding reported how important it was for them to feel able to take part from the safety of their own home. And also singing while muted on Zoom helps enhance the existing failure-free environment. Last year, we actually increased the number of sessions that we were offering, and the group ran every week of the year apart from Christmas. So we really believe in a long-lasting, sustainable and reliable group that supports our participants. We also introduced an open mic section where the group share solos, read poetry, or share something they've made during the week. And it seemed that the group were much less inhibited to share personal stories and songs as they were in their own homes. I wouldn't have ever thought that some of the group would have sang a solo in front of everyone when we were all together before 2 years ago. If I could switch to the next slide, please. Thank you. Last September, in between lockdowns, we visited the homes of 4 of our inspiring group to create a series of short films that told their stories. We work with a brilliant filmmaker, and we have done for the past 10 years, that helps us create lots of these. There's lots more of these on our YouTube. Andy has been part of our Breathe Sing programme for 4 years, and we're going to watch a short film about him now.
My condition is called idiopathic pulmonary fibrosis, but it affects you with shortness of breath, as if you've been running, but it's like that all the time for any sort of effort with me. It's progressive and there's no cure for it. So, and every now and again you get a flare up of the disease, and I'm now on oxygen 24/7. That's a bit better. Ah, hello. The singing relaxes me, and the warm up before you start is like any warm up if you're doing exercise, because you're exercising the lungs. It's singing through your stomach rather than just out your breath. And we've all become friends. Oh, when the saints go marching. We were rehearsing in the Royal Festival Hall, which is quite empowering. But from home, well, we all didn't know what to expect, but actually it's very good. If you don't feel quite well, you can still do it. And yeah, we're all communicating more than you do before lockdown, really. Shine on me. Shine on me. After the session, it's a mental feeling of well-being, actually. If you're well, you're well, rather than ill. And it is thoroughly worth joining. It's good work that should be carried on.
Bye, everyone. Love you all.
Bye.
Bye. Bye.
Well, first of all, I'm really surprised because he always hated singing. He always said, "Oh, I can't sing." But I have to say, it really does give him a lift. He really enjoys it. He looks forward to it.
It's something to look forward to in the week.
Yeah.
It really is.
It takes him away and it makes him forget what he's got, but at the same time, he's breathing as he should be. It's just an all-round thing, really, very beneficial.
So I hope you enjoyed that film, and please excuse our old branding on the end of that video. So I also want to talk to you about evaluation of our work that's really important in what we do. It's a key part of our work, and it's embedded in every project from start to finish. And each of our programmes is backed by data to support our creative approach. Last year, we carried out a thorough external evaluation of our work in a very tumultuous year, and one in which we had to adapt very quickly. So a slightly odd year to do a big evaluation, but that's external funding for you. So last year, we had a relatively normal start to last year. We were still able to run our programme as normal with public events in the hospitals. And overall in the year, we were able to run 237 events. And 90% of our participants across all programmes reported a positive impact on wellbeing in the period before COVID. And then during COVID, with lots of other varying factors affecting this reduced slightly to 88%. Our Breathe Harmony NHS Choir single, that's the stats, 74,847 views of our online single. And the stat at the end I also wanted to mention is 61% of respondents across Guy's and St Thomas believe that arts programming to be an essential part of good care. So I just wanted to highlight this and put it into context slightly, that we ask people, are the arts for you as part of your care an added extra? Are they fine, take it or leave it? Are they important or are they essential? So 61% of people said that this was an essential part of good care. If I could have the next slide, please. Here we are. And then to dig a little deeper into our Breathe Sing group, this was the response from them, their evaluation as well. And just to say, the number there is 15 patient participants, and this is actually the recommended number, the group size of a Breathe Sing for Lung Health group to feel the benefits for everyone. And the quote there on the bottom right is from one of our group who was particularly unwell. But she said that singing has helped improve her lungs by 10%, as told to her by her consultant, and how singing has helped her in that. Before the pandemic, as Andy mentioned in his film, we used to meet up at the South Bank Centre, a non-clinical environment where they felt more like a group of friends. And this summer, we've also been able to meet up a couple of times on the South Bank Centre's roof terrace garden, which is open to the public, which I definitely recommend you go and have a look. The first time it was windy and rainy, and the second time it was 28 degrees, but that's British weather for you. But it was really amazing to be back with the group in person, see each other, and also our songs, lots of them are taught in harmony, so we haven't been able to hear those harmonies on Zoom, so it's amazing to hear all those voices around us. And participants told us how much that meant to them to be back together. We also we're kind of offering a hybrid version at the moment where we'll meet up in person, but mainly online. So we're offering to both people who are online and people who aren't. And a bit about the development of our Breathe Sing for Lung Health programme. We've now expanded into Warwickshire after we won a tender put out by Warwickshire County Council early this year to run 5 groups of 10-week programmes. And one of the Warwickshire group who has just completed the programme told us that I've never had so much energy and felt so well. I no longer fear getting out of breath because I learned how to slow things down and get control back. This course, along with the rehab, has been the best thing ever and needs advertising everywhere. I really can't thank you and the whole team for helping me really live again. P.S. walked 4 miles with a £15 backpack, pushing a wheelchair, and yes, a little out of breath, but wow, I did it and felt great. Couldn't have done that 11 weeks ago. And this is from a participant who's been dubbed as Rockstar Steve. If I could have the next slide, please. So I also wanted to highlight a couple of other projects that we have been a part of and been involved in. This is Art by Post, again at the South Bank Centre. No, we're not sponsored by the South Bank Centre. We just work closely with them and they very kindly offer us space there. And this was a project that began during the pandemic and reached 4,500 people UK-wide in their homes, and creative booklets were designed by artists and sent through the post, as the name suggests. And then participants would go through these booklets and follow some of the instructions or suggestions on how to be creative or make something and send it back. So our Breathe Sing group, several of them took part in this project. They wrote poems, and these have all been collated into an exhibition that's now on display in the South Bank Centre. That's open to the public and is also touring the UK over the next year. And this is Alan on the right here, and he is one of the core members of our group who is there every week. And I think it's fair to say he was the most skeptical about singing and how that could help his breathing. He's had a number of health conditions over the years. And at the first session, he kind of thought, you want us to do what? You want us to sing? And then he has now written a book of poems, which has been published. And he's part of the South Bank Centre. So we're just really inspired by his positivity, despite, as you can see there, he's carrying around some oxygen with him. So his condition has been up and down, but he's just the most positive person despite it all. And secondly, I wanted to talk about If I could have the next slide, please. Excuse me. This is a project called the Singing Hospital. And this was a really special project and performance by 3 Singing for Lung Health choirs, performed to an audience at the Royal College of Physicians in London in 2019. And this performance was commissioned by Arts Council England and produced by the team at the Royal Brompton. And it marked the 10th anniversary of Singing for Lung Health. And composer Victoria Hume, who's also a pioneer in the arts and health sector, she created a new piece of music that was performed by 50 singers. And it was a real celebration of the achievements and many of the patients who had benefited from the programme over the years. So Victoria, she went along and she talked to them, and they knew her fairly well already. And from their discussions, from the phrases or the words they said she put together a composition which was premiered at a really special event, very moving and very emotional. And finally, I wanted to talk about some signposting. If I could have the next slide, please. So as I mentioned, British Lung Foundation are really behind this initiative, and this map shows the 70 Singing for Lung Health groups that are across the country. And this is from their website, and they have lots of signposting on there if you're interested to find your local group. However, it's sad perhaps to say that this map might not look the same today as it did 2 years ago. But lots of groups are finding inventive ways to keep connected and keep singing. And there's a few other links on there that might be of interest. The musical breath is a really interesting one. This is the website of Feeney Cave, who is really a pioneer in Sing for Lung Health and has trained hundreds of singing leaders. And there's a few choirs on there as well, which aren't specifically lung health choirs, but are open and online choirs as well. And the Singing Hospital project, which I just mentioned, if you search that on YouTube, you can watch the full video of that. So thank you very much for having me today. Finally, you're all invited to join a taster session of Breathe Sing at today's event at 11:55 with one of our specialist Singing for Lung Health facilitators, Edmund Jeffrey, who has been working in the field for a number of years, and he'll be leading one of the breakout sessions. So I'd really encourage you to take the opportunity and try it for yourself. Feel the benefit of singing, and I can almost guarantee you come out feeling boosted, lighter and smiling. And thank you very much for having me, and here are some of the details. If you wanted to find out more, you can email us, have a look at our website, lots more films about our amazing participants on our YouTube as well. Thank you very much for having me.
Thank you, Natalie. So what an incredible organisation to be a part of. The patient quotes were amazing, and we really would encourage anyone who's interested to join the breakout session later. Can we just say thank you to Slater Gordon for sponsoring that session. We're grateful to all of our sponsors today. As we've been reminding you throughout the morning so far, just please continue to ask any questions that you might have, and we will put them to Natalie and the rest of the panel later. I know that there was some connection issues just at the start of the day. Please rest assured all the sessions are being recorded and they'll be available later on the Meso UK website. So don't worry if you've missed something that you particularly wanted to see, it will be available to you later. We're now going to move to a short comfort break, so you can all go and grab a quick tea or coffee, and we will start back here again at 11:05. Thank you all so much, and we'll see you again soon.
Welcome back, everybody. And if people have had problems logging in up until now, joining us up until now, just to let you know that the sessions first thing this morning have been recorded and will be available to you. We apologise, there's always a little bit of a glitch when it's online and virtual, isn't there? I guess it's par for the course these days, many apologies. But you will be able to access the sessions that have come before once we finish the day. They'll be available on the Mesothelioma UK website. So we now have two of the nurses from Mesothelioma UK to present to you. First of all, we have Liz Darlison, who is going to present to us a presentation on the Health Companion, which will be useful for patients to help manage and track their own disease. Liz has enjoyed over 36 years of clinical practice at the University Hospital of Leicester, 21 of them in thoracic oncology. And currently she's a consultant nurse at the University Hospital of Leicester and is also the CEO of Mesothelioma UK, the national charity for mesothelioma. Leah Taylor is then going to tell us about the clinical trials app. Leah is a Mesothelioma UK team leader and clinical nurse specialist based in North Tyneside General Hospital, covering the northeast of England. Leah qualified in 1996 and has been a lung cancer nurse specialist for 10 years. And previously, Leah worked at the Marie Curie Hospital in Newcastle and within medical education. And this session is sponsored by Irwin Mitchell. Thank you.
Hello everybody, my name is Liz Darlison. I'm Chief Executive of Mesothelioma UK and I'm also a nurse consultant at the University Hospitals of Leicester. I'd also like to introduce Lee Weems. He is a director of Dash Global, our commercial partner who has helped us to develop this health companion that we're very grateful to you for agreeing to review the companion. So I also would like to acknowledge my colleague Lorraine Creech, who's also been very involved in the development of this prototype. So just to give you a bit of background, really, a few years ago now, working with Dash Global, Mesothelioma UK developed a patient experience or a burden of disease, should I say, tool so that we could really work with patients to measure the impact of mesothelioma on their experience of care, on their symptoms, on their quality of life and on their finances. We completed that study and part of that study had a digital option, so patients could complete and provide all that information using a digital platform. And it worked really well. We were delighted once we'd completed the project, but it struck us that we shouldn't be doing this just occasionally or now and again. This should be something that we collect as an ongoing project, because the actual impact and the experience of care is extremely important when we're looking at the development of health services generally. So with that, working with Dash Global, as I said, we have developed this digital prototype of the Health Companion. It's available currently for lung cancer patients and for mesothelioma patients. So that's the two disease areas that we're currently developing the prototype in. So just to explain a little bit how you might learn about this as an opportunity as a patient. So the intention is that the cancer nurse specialist that patients meet in the hospital setting will introduce the opportunity of being involved with the Health Companion. They will provide patients with a piece of information, and if patients want to get involved or explore it in a bit more detail, they will consent for the nurse to provide their contact details to a Health Companion manager. That will be forwarded on to the Health Companion manager, and with a few basic details, you know, name, mobile phone number, email address, your NHS number. The Health Companion manager will upload that onto a backroom system, and the patient on their chosen device, whether that's a tablet by email or whether it's on their mobile phone, will receive a link via text or email that they can click on that will open up the Health Companion. And this is what it would look like on your mobile phone. So this is the lung cancer Health Companion. And if you opted to take up the opportunity, when you first click on the link, this is what you would see. Now, I hasten to add, this is not an interactive tool. So anything you put onto it will not be notified to your clinical team, to your nurse specialist. It is intended for you to take with you to your appointments so that you can share the content of your health companion. You might use it with your family and friends to show them the pattern of your symptoms or the pattern of your quality of life, but it isn't interactive, so it doesn't flag any concerns to your healthcare team, and it's really quite important for you to know that. I think I should also add that the health companion manager will be available to support you with any troubleshooting, and the intention is we have made it so user friendly that you will not need a great deal of support with troubleshooting. And that's what this is all about. Your reviewing it is really about looking over with a fine-tooth comb the companion and flagging up to us now, as we're developing in the final stages of developing the companion, flagging up to us any little glitches or things that you're not quite comfortable with or that you don't find very user friendly. So just to explain a little bit further, there are 4 sections to the companion after the initial setup. So the 4 sections are your experience of care, your symptoms, your quality of life, and the cost implications of your ill health. This is the initial setup, and Lee's going to click through some of these pages. So when you first log on, can we just go back to the first page just to show, as I say, this is what you'll get. You'll click on that start button. It will take you through a basic introduction. We're going to ask you to reconfirm your contact details, change your password, and reconfirm your consent. So Lee's going to just take us through that. And there's also some details there about the health companion manager's contact details. So this is reconfirming your consent, the date that you started, and whether you would like to complete it in the next week, the next month, or in 3 months. And you can have some control over that if you would like to. And that's one of the questions we're going to be asking you as you review it. And this takes you through to your home page or your dashboard, whatever you want to call it. So as I said, let's look at the initial setup. So when you first join the health companion, there are a number of questions we're going to ask you about the state of play now with your health problem. And this is to set the scene or to create a benchmark of where you are and what's happened. So if we just look, this one, it's click on, there's those that you've completed, and so they will move over to the completed column once you've done them. But in the still to do, when you first open up the companion, there'll be a whole list of things there that we want you to complete. Very quickly though, it's not meant to be too onerous. So if we click on your details, and you'll see there, this is more of a reconfirming, and this data should be already entered for you. We just want you to confirm that it is correct, and then to change your password. So you can password protect. Some more basic details, your name, date of birth, postcode, ethnicity, a bit about your height and weight. And that's it. Now, with regard to your clinical history, we are interested in your asbestos history and your smoking history, because these are all predisposing factors to developing a malignancy, a chest malignancy. So if we just click on asbestos history, for instance, we're going to ask you just a little bit about, from your memory, have you ever been exposed to asbestos? And Lee's just going to walk us through this. A bit about your career, what you did for a living. You might have had 3 or 4 jobs. And then if you've been offered any help to identify your asbestos exposure, we're just interested to know a little bit about that too. We're also interested to know if you've been in the armed forces, and if you have, which service and how long you've served for. And these are all very helpful when we're creating a clinical picture. We're also interested to know if there's been any family history of mesothelioma. And it's a similar thing for smoking. I don't think we need to go through that. But also in this initial setup, we are interested to know about your initial experience of care. And if we could just click on that, Lee, as well, just have a little look at some of the experience of care. So We want you to put in the first date you experienced symptoms, the approximate date you were diagnosed, how many times you went to your GP. A lot of these questions are based on a national cancer patient experience survey. And what we want to do is to collect data about people with your particular type of cancer and compare it to the national cancer patient experience survey. So the explanation of meso, was it understandable? Was it given in a sensitive way? And so on. And so in this initial setup, we're just going to create a view of what your initial experience from being diagnosed was. So that's the initial setup. And now if we can just go and look at the 4 sections. So periodically, you will be asked to complete questionnaires once you've signed up to the Health Companion. Those questionnaires are about symptoms you might be experiencing. They're about your quality of life. And there will also be some questions about the financial implications. So your quality of life, your experience, your symptoms, and the cost implications. And that again is your homepage or your dashboard. And you can click on any one of those and see where you're at with. So if we just perhaps go to my symptoms. So if we click on my symptoms, it will tell you when you last completed the symptoms survey. And if we can just go to next. And this is the symptom survey. It's a validated tool that's used across all sorts of different health problems. Have you been short of breath? Are you losing weight? Are you thinking clearly? Have you been coughing? Have you got a good appetite? Any tightness in your chest? Is your breathing affected? Lack of energy? Pain? Nausea? And any side effects from treatment? And are you content with your quality of life? And that's it, completed. And you can save and finish that. Before you do that, you can choose when you want to next complete that symptom survey. It is likely that we, the Health Companion Manager, will be asking you to complete it at 3 monthly intervals. But if your symptoms are altering quite frequently, you might want to complete it more frequent than that. And we would welcome you to do that. So we are going to be asking you about that when we ask you to complete the review questionnaire. Save and finish. If you wanted to then look at your summary of your symptoms, there is an option on the bottom menu for you to go to your summary. And then Lee can just click on the symptoms and you can view this in different ways. So it will tell you how many times you've completed it and over what period of time. You can look at a footprint chart that will give you a pattern. So it looks like a spider's web, and the center shading will lean towards the symptom that is most prevalent for you, or you can look at it across a time chart. And that will show you, it will plot on there over a period of time which symptoms have been more troublesome. So if we can just now perhaps look at quality of life, this is one of the other 4 sections. So we go to your homepage again, click on quality of life. That's the last time you completed it. If we go to next, this again is a validated tool used in all manner of clinical trials called the EQ5D5L. There are 7 pages to this. So mobility, have you got any problems with mobility? Self-care, can you self-care? Your usual activities, have you got any problem with your usual activities? Any pain or discomfort? Are you experiencing any anxiety or depression? And then this is a sliding scale for how you would rate your health today. And that's it, completed. And then again, you can go back to the summary and you can look at how your quality of life has measured up over a period of time. So how many times have you completed it? What it looks like on a footprint chart. Apologies. And then on a time chart. I also just want to show you your cost section. So this is the third section. And this can be switched on or off. So if you really don't want to enter information about the cost implications of your ill health, then that's entirely up to you. And you can switch this on if you don't want to take part in this part of the Health Companion. It's really helpful for us when we're doing research, for us to be able to report on the cost implications of somebody's ill health. So we'd appreciate it if you did, but we completely understand that some people want to keep their finances quite private. I think the other thing that I should mention as well is that throughout, just let Lee finish, throughout any period of time that you're signed up to take part in the Health Companion or to use the Health Companion, you can withdraw at any time. There is no obligation to continue. Of course, we'd be very grateful. The longer we can collect information about people's experience of care, their symptoms and their quality of life, the better. I also wanted to just explain that there is video help throughout. So rather than having to read pages of, accepting policies, procedures and all the rest of it, we are in the process of creating videos about each section. So you can just click on the video, listen to it, and it will tell you about that section of the Health Companion. We have several meetings planned with patients and with healthcare professionals over the coming weeks, who will all be reviewing the Health Companion. And we're expecting people to, make comments and to say they didn't like this or they like that. That's exactly what we want you to do. We have prepared a questionnaire with a few questions that about things that we specifically need your advice and support on. So we'd be really grateful for you to complete that. But there is a section at the end on other. And so any comments that you've got, even if it's down to the colour or the size of the print, it doesn't matter. Any comments would be really grateful for. So with that, I think I'm just going to check with Lee that he's happy with that we've showed you sufficient content. Lee?
Yeah, I think
yep.
Done a good job there.
Lovely. So with that, we'll leave that with you. Please talk to the person presenting it to you. Contact any of us back at Meso UK. We'd be glad to talk to you about it further. And once again, a big, big thank you. We really are appreciative of your feedback. Thank you.
Thank you for inviting me to present the Mesothelioma UK Clinical Trials app. My name is Leah Taylor. I'm a team leader, a clinical nurse specialist team leader based in the northeast of England. So I'm just going to give you a bit of a whistle-stop tour today of the app. We'll start by how you get the app. I guess before that, to think about why we've brought this app to you. And the reason for that, any of you who've been with us for a while might receive our newsletter, and that has a clinical trials pullout. And that clinical trials pullout over the last few years has got bigger and bigger and bigger and double-sided. And it's published quarterly, and that makes it quite difficult to keep that information live and current. So we really wanted something that you could have in your pocket, which that trial pullout had become a bit cumbersome, a bit too big to put in your pocket and take to clinic, and something that we could keep updated as live as we possibly can to bring you all of the information about clinical trials. We wanted to have everything in one place so it was easy to find, and we also wanted to have the information written in a non-medical way, in a way that everyone can understand. And sometimes the information around clinical trials is quite complex. So that was really the aim of bringing you the app. And if you have been following us for a while, you'll know that we've been saying for a long time, the app is coming soon. And like everything, the app was affected by COVID, the development was halted. But thankfully, a couple of months ago, beginning of July, we managed to finalise that app and get that out there. So we're really pleased to show you the app today. So in terms of getting the app on your phone, whether you're on Apple or Android, all you need to do is search mesothelioma or Mesothelioma UK. You may have, we do have a QR code. You may have been given a card by your nurse specialist. We have some little app cards with our QR code on, and you would just scan that and download that onto your phone. The app does not collect any information about you. You don't have to register, and it's free to anyone who wants it. So when you first download the app, you'll see our little forget-me-not icon on your phone, and you tap on that, and this will be the home screen that comes up. The other thing we wanted to do was not get lost in the app. So not have lots of links and lots of pages to navigate so that, 5 minutes in, you forget where you were in the first place. So the app is really quite simple with as few links as possible. The first section, really, we wanted to bring you some information generally about clinical trials and sort of demystify that a bit, because clinical trials are quite complex and they're not suitable for every person. They're given at different stages of drug development. They're given at different stages of an illness, different stages of treatment. So we wanted just to break that down a little bit and help people understand what trial might be suitable for them at whatever stage in their mesothelioma diagnosis. So in that about clinical trials section, we have a bit of information about the type of trial, which it gives you there, sort of treatment trials or observational studies. We have information about stages of treatment, so whether it's a first line or a second line, or what maintenance treatment, symptom control, what all of those things might mean to you. We wanted to give a bit of information about fitness for clinical trials, and so there's a bit of information there about performance status, which you might have heard your nurse or doctor talk about. And then a few sort of questions. What might I need to think about if I'm going to consider a trial? Will I need to travel? Is it free? Is it on the NHS? Things like that. And, hopefully this app will be a developing thing. So any more questions that people pose to us that we think are relevant, anything you think should be on there, please do let us know. And then how to take part in the trial, which, that you want to know that if I've seen a trial and I think that's applicable to me, what's my next step? So really, to find a clinical trial, as I say, it's very, hopefully very straightforward. You would click on the Find Clinical Trial tab, and that would bring up a list of options. So if we look, for example, at the first line trials, and there's one current trial within that category, so we click into Beat Meso box. When you click into that box, it will bring up all the options, all the sites that are taking part in that study. So each site has its own information. So all of the information is pretty much the same, apart from the address of where it's located and sometimes the contact detail. So it will bring up all the options, so you can have a glance and see what's my nearest site, where might be accessible to me. And then in the middle, where you see the page with the Meso UK Forget-Me-Not icon at the top, that's your main page of the trial, the main information page. And you just scroll down that essentially to read the information, and it has information about what the trial is, the type of treatment in the trial, who would be eligible for the treatment, and whether or not it's randomized, whether what you can expect in terms of how the treatment will be given, how long it is. And then there's some inclusion and exclusion criteria about whether or not you might have other conditions that, might make that trial unsafe for you. And that's essentially that information. There are a few features of using the app, and one of those is the map, the ability to see at a glance where the studies are located from you. And if you click on that map button, you'll be able to see across the UK where they're all located. The little pins haven't actually dropped into the sea. When you do zoom in on them, it'll show you that they're in the right place. So I've just put the one that's nearest to me there, and that's at North Tyneside. So it'll show you exactly where that trial is located, where the hospital is. So To find specific information, if you go onto your trial page and you click the icon at the top, that's shown there with the green arrow, that will bring you into the specific map for your page. And what you can actually do is go into the directions by pressing the directions button at the top. And that will give you, if you allow it to, it'll bring you out of the app and into a map. Is sort of a direction app website, and it'll bring you all the information door to door from where you are to where the trial is. The other handy thing that you can do is you can identify trials that might be interesting to you. So you can star them and put them in your favorites list. And you do that just by hitting the star on the top of that trial page, and it'll bring up a little box that shows you it's been added to your favorites. Then to find those, if you go back into the first page and you hit My Starred Trials, it will then bring up that list that you've created. And again, you can click on a map, which shows you from you where those 2 trials are located. When you're in the map, you can click on the pin and it will show you what that trial is. And if you click on Show More, it'll take you right back into the trial page. So you don't have to keep navigating back, it will just take you there. And then to delete it off your favorites list, in the main trial page, there's a delete button, and that'll just take it straight off. In order to use the location and the push notifications in the app, you do need to have those set in your settings, and that's just the cog at the top on the top page. And you have to enable location services and allow global announcements. The push notifications, I think probably by the time you see this, we will have sent out 2. So it's not going to be, the app is not going to be pinging away day and night with changes. It's just any key changes. If we add something to the app or a trial closes, we might want to let people know about that. So it shouldn't be pinging away day and night. There's some links at the bottom of the home page, and that just takes you quickly into our social media, so into Facebook and into Twitter. And then we have our contact page as well, which would take you to the phone number, the email, website, and our YouTube channel as well. As I said, we really want this to be fluid and current. So if often we don't get the immediate updates from trials. We sent out for updates regularly, but if you see something in the app and that's not quite right, if you see a study and you think, well, actually that is offered in my local centre and you haven't got that listed, then please do get in touch and just email us on our contact email, and we'll amend that as soon as we can. Thank you.
Hello, thank you, Liz, and thank you, Leah. Please keep your questions coming in. We have a few questions and comments already, but keep them coming in. Doesn't matter what your question is. Doesn't matter if it's a big question, a small question, you think it might be a silly question, please send them in to us. Our next speaker today is Andrew Payton. Andrew is the co-founder and chair of the Metro Safety Group, and more frequently of UCNAR, the UK National Asbestos Register. He has been helping others to protect both property and people. This has been his career for the past 30 years, and we're delighted to have you here to speak to us today. Thank you.
Great. Well, thank you very much. Thank you for that very nice introduction. Actually, these days I spend all of my time now, or 95% of my time, on what we call, well, it's called different things, UCNAR. We call it UCNAR. It stands for UK National Asbestos Register. And just very briefly, it's a new social enterprise. We started it just as the pandemic was beginning. It's a regulated community interest, which means its profit isn't for the shareholders, but for its stated purpose. And its simple stated purpose is to protect public health. And that's through the prevention of avoidable exposures to asbestos. And we do it in 2 ways. We think we can do it working collaboratively with a wide range of stakeholders, including duty holders, but also using today's what we call asbestos smart QR technology, which now is one of the things that everyone's familiar with. We are also, for those of you that don't know, we are proud to be very much so in charity partnership with Mesothelioma UK, who frankly I'm in awe of what you guys do. It's amazing what you guys do. It's a fantastic job. Who also receive what we call 5% of what we call our asbestos smart revenues, which you'll see a bit about in a moment. This coming up here is a little video that we're actually using for a crowdfunding investment raise on the Ethics Social platform. And we're using this to let people better understand what we're doing and what it is we're trying to achieve. But in a nutshell, what we want to do is to use today's technology to help build a national asbestos database of all the registers that we know exist, which means that people working or visiting workplaces that contain asbestos know where the asbestos is located, make sure it doesn't get disturbed. And unfortunately, because, which we'll explain later, people don't get to see this information or in a way that's useful to them, there are unfortunately tens of thousands, possibly more, of accidental exposures every year. And of course, that puts everyone at risk. So, well, let's play this little video, and then I'll say a few more words just after that. Thank you. Coming mostly from a fire safety background, I don't think I fully appreciated the scale of asbestos as it is in the 21st century. I thought it was a 20th century issue, mostly. However, as the deaths have continued to rise beyond predictions, the scale of how widespread it is, and as I looked into how many exposures are likely to be happening every year, realized that that isn't actually the case. Really good news is that after conversations with different people, including my co-founder, we think that today's modern technology, which is cheap, widely available, can make a really big difference here. And that is why we're here. So thank you very much indeed for taking the time to look at this video and our prospectus.
This disease for 20 years or more now, and it saddens me beyond measure the number of people that I see that have had occupations that have exposed them to really subtle levels of asbestos. People, when they're diagnosed with mesothelioma, like when many of us face a crisis in our life, it often brings out the best in people, and they will always often say, please do all you can to prevent this happening to anybody else.
The truth is that in the end, it's not about technology. It's about the efforts, small efforts of lots and lots of people because of the scale of the issues. The really good news is that it is something we can do, and it is relatively inexpensive, which is great news in today's world. So thank you very much indeed.
Great, and thank you very much for showing that. I hope it gives the gist of what we're trying to do. I mean, the problem that we're really trying to solve is that unfortunately asbestos is sort of everywhere, It's in 75% of schools and 90-odd% of hospitals and 1 in 5 workplaces and 1 million odd homes. And the thing is, it's meant not to be disturbed. And while that is true for major projects, which are much better managed, you've got 1 million people going in and out of buildings, potentially disturbing asbestos every day. And not everyone's at risk, as you'll know. Tradespeople are amongst the highest at risk, probably 90 times that of the general public. But teachers and nurses too have a higher rate of mesothelioma than you want, because they're in schools and buildings, old public buildings, where the asbestos can easily get disturbed. There's so much of it. And the problem is very straightforward. People don't know where the asbestos is, and the information doesn't get to them, and it should do. And often the information doesn't get to them in a way that is comprehensible. But the good news is the information actually exists, and we just want to make it accessible 24/7, freely to those people without hindrance, so that they know where it is and don't disturb it. And the only people who pay for this are the duty holders, and we're talking about less than a couple of £100 per building per year with asbestos, so minimal cost. And we help everybody, in essence, by getting this right. The way that we're really approaching this, though, is working with what we call key stakeholders. And here we're talking about a lot of different people. So we're talking about major organizations in the public sector, NHS trusts. We're talking the social sector, housing associations and education, talking FTSE 100 companies, property management companies. And we're working with these. If anyone has been following us will see we've got Knight Frank and Savills on our side. We've got a lot of schools now taking interest. We are working with leading asbestos consultancies because we need them on our side, and some of the leading IT systems providers too, who hold this information. We're in advanced conversation with somebody there. But there are campaigning bodies and charities and health and safety professionals and even insurers. So there's a lot of people that we need to be working with, because it really is about getting all of those people actually on our side. I've got just a couple more minutes because I don't want to take up too much time from people. I think really, to wrap it up, I think there are 2 things that I really want to add. I think it's important for people to know what our aims are. We'd love in 5 years' time, which is the time I've dedicated to saying to get this really working, to have about 80% of public buildings on the National Asbestos Database Register. That's what we'd love. But really, we want it to be the norm for people to know where asbestos is in the workplaces they are in or visiting, especially contractors who are most likely to disturb it, and actually to be aware of the care that simply needs to be taken as a result. That is fundamentally our vision. It's fairly straightforward in that sense. And I suppose what I would say to you there is everyone, I think, can play a role in this. And what can you do? You can spread the word, basically. You can go onto the FX website, if you like, and see a little bit more about what we're planning to do with our money, and that's fantastic. You can, if you're on social media or any of you on LinkedIn, you can follow us there. You can actually introduce people and tell them to attend our webinars that we actually have a couple now every month where they can find out a little bit more. Go onto the website. All of those things. And mesothelioma, remember, will gain. Mesothelioma in the UK will also gain 5%. And there's even a 10% introduction fee for people who sign up as well, which you may want to give to Meso or your own charity or for yourself. We're just trying to get as many people involved as possible. And really, it's a bloody tragedy that asbestos is still here. We'd love it all to be removed, but until it is, can we at least do our best to manage it safely? And I think that's probably enough from me. Enough talking for now. So thank you very much. I would like to hand back now, and somebody else can do the talking. Thank you.
Thank you, Andrew. And thank you to everyone who's spoken this morning, to Ivan Cartwright, to Natalie Craven, to Liz Darlison, Leah Taylor, Andrew Payton. We are going to begin our panel session now, and most of the speakers have been able to join us at the panel, and we've got a few questions to put to them. So I'd like to say hello and welcome back to Natalie, Andrew and Leah. Hello, can you all hear me okay?
Hi, Carolyn.
Hello. So we've got a few questions that have come in, but just before we start the questions, there's been a lot of positive comments that have also come in. Natalie, if I could start with you. There's been lots of comments about how amazing the initiative is, and it's, you know, comments on how it's a great idea. One of the questions is, you know, if you want to join a group near me, like not near me, near the person, how can they join?
Yes, I think there's a number of routes in if you're interested to join a Singing for Lung Health group. Some of them are set up for specific lung conditions such as COPD or IPF, but others such as ours accept a much wider range of patients. So, for instance, we during the last 2 years, we also accept patients that have been on a ventilator in ICU, etc. So there is a variety of groups out there. The British Lung Foundation, as I mentioned in my talk, is a really good place to start. If you just search singing on there, you'll bring up the information on there, including the map that I mentioned, so you can find a group near you. And if you don't have a group near you, I would suggest going to your local hospital, and hopefully lots of hospitals have charities, and lots of hospitals also have arts teams who work within the arts and health sector who will know about Singing for Lung Health. So a good way in is lobbying your hospital charity, and a good funding route, if there isn't already one there, is to go to your lung clinic and get a member of staff there to lobby their charity internally to raise or to allocate funding for a Singing for Lung Health group. So there's lots of options, and as I mentioned, there are hundreds of Singing for Lung Health trainers around the country. Lots of them are without groups, sadly, because the funding seemed to have run out a few years ago. So there may well be a Singing for Lung Health facilitator near you that might be able to get a group going. So I hope that helps slightly.
Yeah, I mean, I think there's a lot of people joined today that would like a mesothelioma group set up. So yeah, maybe that's something we could look into. The other question that's come in, and I have to say I thought of this as well. Can you join if you can't sing?
Yeah, definitely. Yeah, I think as Edmund in the session in a little while will introduce, it's all about everyone can make a noise with their lungs, with their breathing, and lots of it is about the breathing. That's where we start from. We just do breath exercises. It's not about singing in tune. It's not about singing perfect harmonies. It's just about using your breath and what your lungs and your voice can do. So it's absolutely not about being a choir and putting on performances. So one of the examples I use, that group had been together for almost 10 years. So that was a huge build up to reach that point. But lots of groups, they're just there for a supportive and group environment. So absolutely don't need to think that you can sing very well to start with.
Thank you. Leah, there's been a comment come in about the app, the clinical trials app, actually from someone who's already downloaded it, and they just wanted to say thank you. It's really user friendly and much better than the methods the people had before of trying to track down what trials are available and where. And really, it was just a message of thanks for all the hard work that's gone into setting up the app. It's been gratefully received.
Oh, thanks, Carolyn. That's really good to hear. Thank you.
I don't know whether you'd be able to answer this question or not, because more about the companion app that Liz had mentioned. It's obviously on smartphones and things. Is this something, and would the trials app ever be available on a PC?
Certainly not currently. I think the reason for it being on mobile devices was so that people could have it with them, and especially if they went to clinic and things like that, they could have it there. It's a good question, and one I don't actually know the answer to, so leave it with me and I will try and find out.
Sorry.
That's all right.
And to Andrew, if I could ask a question, if you are aware of asbestos in the fabric of a building near you, could you just maybe go over is there any way of registering that with your service, just to kind of recap how people would do that?
I think at the moment, if there is asbestos in a building, somebody has that information and they are called the duty holder. They are the responsible person. It can be an organization, can be local authority, but they are the responsible people. It is their information. They ought to make it public, but it depends how much and all sorts of stuff there. So really the thing to do is to go to that person or that organization and say, look, this is information. Can you speak to these guys? We think they might be able to help you. You have to go to the people who actually hold that information. And those people have a responsibility. They're responsible for managing that asbestos safely until they remove it safely. And part of that is letting people know who might be at risk of asbestos disturbance where it is actually located. Now, the culture's changing, but it's not changing fast enough just yet. So some people go, oh, I don't want anyone to know about asbestos in my building. Post Grenfell, I promise you that will all change.
And is there any way, another question just come in just now to ask, is there any way that we could encourage, or maybe the government are already involved in supporting UCNAR? Is there a way of us engaging or helping promote that relationship?
Well, I think at the moment what we have done is we submitted a paper along with Respublica, which is a think tank, public think tank, and we're a side paper to a major paper about the HSE, or the Department of Work and Pensions is doing an asbestos management review. One of the suggestions in there is to have a national asbestos database, as other countries actually do. So I think, I don't know how exactly to support that, but I will have a look and see is that, I think there will be findings coming out of this, and the public needs to make a bit of a stink overall about the fact that there is asbestos in schools and hospitals, and people are saying it's managed safely when everybody knows it's not. That's really, write to your MP and say, what are you doing about it?
And
so
I suppose
it'll create a bit of momentum around the fact that they have rather shied away from the problem.
I suppose that's a way for devolved to get involved as well, as to write to the local MPs. So the devolved governments can get involved as well.
Yeah, and if you want to cause a little bit of a problem, start writing freedom of information requests to schools and NHS trusts, asking them to see their asbestos register. They hate it because they don't even have the information to hand, even though they've got it somewhere. Yeah, a bit of a nuisance, really, I would say.
Well, thank you. Thank you to everyone who's taken the time to present this morning. As I say, there's been lots of good feedback. All of the presentations today have been recorded and will be available to watch for some time to come. Do any of you have anything you'd like to add that you've not had the opportunity to say? Or no, put you on the spot? No. So what we'll do then is we will move on to the breakout rooms. Now, this has been written down for me just so that I get it right. So in a minute, we'll open up the breakout rooms. These will run for 45 minutes and will be followed by our lunch break. The 4 breakout rooms are carers, peritoneal patients, managing breathlessness, and Breathe, Sing for Lung Health workshop. You can select which room you would like to join, and the instructions of how to choose a breakout room are on the screen now. If you're unable to choose a breakout room, please write the name of the session you wish to join in the chat box, and one of the team will manually move you to the room as soon as possible. If you don't want to choose a breakout room, that's absolutely fine. You can have a longer lunch, and we'll start back here again at 1 o'clock. The breakout rooms are now open, so please follow the instructions and enjoy one of the sessions. Thank you.
Hey everyone.
Hiya.
Hello.
Hello, I'm Rachel from Mesothelioma UK. I'm just going to introduce Edmund, if you want me to. Edmund is going to host this session called, let me just get the actual title. It is Breathe, Sing for Lung Health Workshop, and it's with Edmund Jeffrey. Natalie, I'm not sure if you wanted to say anything else as well.
Yeah, just if the rest of the group, perhaps we might have to people might join at some points throughout the start of this. So if we can just mute people while Edmund is doing his intro. But thank you very much for having us, Rachel. I know you've been behind the scenes helping organise this, and we're really, really happy to be able to lead this with you today. Thank you.
Hi all, sorry about the problems. The
pursed lips.
Speak completely. I sent an email and I tried.
Hello, I'm really sorry about this. Not sure what's happening.
We're there. We're in the room, I reckon now.
But yes, I think people are able to join now. So
Edmund, I think you're. Oh, I can't hear you. I don't know if anyone else can hear you.
I'm in. Can you hear me? All right.
Yeah, we can hear it.
Oh, okay. I can't hear. Oh, okay. I'll figure out on my side.
There's a few more people joining anyway, so maybe I'll just give a few more seconds for other people to join, and hopefully we'll get there in the end. So I'll tell you a bit more about myself whilst people sort out their sound and get in. I'm a professional singer and I was lucky enough at music college to learn a lot about breath control and breath support. And I've been running singing for lung health groups for about 5 years. And in my opinion, it's just a lovely bit of common sense to be able to give people an insight to better breathing, breath support and breath technique through the most amazing thing, which is singing. But I'm a bit biased, and I'm going to get started now. So I hope you enjoy the session, and I hope that you can all hear and join in. So as I was saying before, just breathing in through your nose and out through pursed lips. At your own pace at the moment, just creating a bit of resistance with your lips on the way out. A little bit of resistance. And we're just going to change that weighting. So it's in for 2 and out for 4. In for 2 and out for 4. And we're just going to increase that out breath. So it's in for 2 and out for 6. One more in for 2 and out for 6. And I just want you to just move your head from left to right as smoothly as you can, almost feeling as if your head is completely detached from the rest of your body. Lovely. And then just a little wobble from side to side. And then when you're ready, just doing a half moon roll of your head. So you don't have to go right the way around, just that little forward half moon roll. And we're just working to get rid of any tension that we might be holding in our neck at the moment. So coming back to the breath, we're going to go in for 2 and out for 6, but this time on a in for 2 and out for 6. And one more in for 2. And the last one out for 8, please. Right the way over the top of your head. And we're going to work our way down our face. So just starting on the forehead, down your cheeks, and then just find that point where your jaw meets. If you lightly open and close your mouth, you'll just feel that point and really enjoy this part of the massage, right the way down to the chin. And even with your thumbs, just ever so lightly underneath your chin as well. So we're going to start bringing the voice into this now, and it's all going to be closed sound. So this is a really safe way, if your voice is feeling a little bit fragile, to warm up your voice without damaging it. So just put a nice massive bit of toffee in your mouth, and maybe not the most graceful chew, one that you might not bring to the dinner table, but just really bring as much of your face into this as possible. Great stuff. And give me a really round mmm, as if you're really enjoying whatever you are chewing. Mmm. And you should really feel this tingling in your lips. And we're going to make the same sound, but we're going to lift our tongue onto our top palate, onto the roof of our mouth. So keeping them lips sealed. You're going to feel this in your nose. You're going to feel a bit of a rumble in your nose. And the final sound, which is my favourite, is the end of song, the NG on the end of song. So song. Just trying to find that sound, the NG, long, throng, whichever word you fancy. And just give me some sirens. Great. So if you're happy to do so, please join me on your feet. So the way that I learnt to sing and the way that I love to teach people to sing has no bells and whistles. So the amount of people that come to Singing for Lung Health sessions and say, I can't sing, that is like the most common words that I hear. You do not need to be able to sing well. That is the job of coming to Singing for Breathing, Singing for Lung Health. You just need to be able to make noise. So I call it, well, it's known as primal sound, and we're going to warm up through emotive sounds that we use every day. So just make sure you've got a little bit of space around you. You're not going to be knocking over all your ornaments or lovely sunflowers. And just give me a nice stretch. Round and down the middle, please. And as you go around this time, just breathe in through your nose and out through pursed lips down the middle. Great stuff. If you're going out of the picture, that's good. It means you're stretching far. And this next time round, we're going to bring in a sigh. So your lovely yawn. Oh, sounding lovely. It's nice to hear people. So one more time. Great stuff. So this is your lightest setting. This is your sigh. If you've got a real yawn in you, I will not be offended if you take it now. It's a very light setting, but it's very breathy. You are expelling a lot of air in this sound, but it means it's a little bit of an inefficient sound as well. So just give me one more of them. I know that some of you might be in shared spaces. You might have next door neighbours like I do. They will think you're a little bit mad, but it doesn't matter. Just go for it for this 45 minutes. So give me a swing of the arms. Again, if I ever ask you to do anything that feels really uncomfortable or that you don't like, don't do it. I'm not the boss of you. I'm just showing you what you can use. So feel in a good momentum. And we're going to bring in our next vocal quality. So this is what I call twang. Just go for me. Whee! Great. Really deafen your next door neighbours. Whee! Great. So this is just as light as a sigh, but it is really, really piercing, this sound. You're making a lot of noise with not as much energy. So one more time for me. Whee! Great stuff. So you should really feel that piercing sound coming through on this twang. The next setting, I would argue, is the most important. in terms of singing. People like Ray Charles, Stevie Wonder, they made their millions by whinging. So just go for me. Oh no! Oh no! Yes, I am absolutely loving hearing you make these sounds. Just give me one more of them. The biggest whinge you've ever had. Oh no! Great, sounding lovely. So I like to bring a bit more of a positive string to this. So we're going to have a lovely positive whinge. We're going to go, oh yeah! Oh yeah! Yes! Great. So you should be feeling a little bit more energy coming from your body in this sound. So just to recap where we are up to, we'll start with our sigh again. Oh. Great, so that is your lovely sigh, almost like you're just having the most musical yawn of today. And then bringing the swing of the arms in. Whee! Great. So this is your twang. This is making a lot of noise with not a lot of effort. Still on a light setting. And then your final one, we're going to do a very musical whinge this time. Just give me, oh yeah, with me. Oh yeah. Fantastic. So really feeling that gutsy whinge. I'm going to go for it. The final one, we're going to go one step louder. This is your yell. So just find your ribcage, wherever that may be. It's slightly different on everyone's body, but roughly in the same point. And just follow that ribcage diagonally up to its kind of center point, where the two rib cages meet. Little squidgy point there. And then create a diamond around your belly button. Great stuff, looking lovely. And just give your belly a bit of a wobble. We just want it to be nice and relaxed. We're not tucking anything in. Just let it hang where it wants to hang. And just give me a lovely shh, 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 shh. And again, shh, shh, shh. Great. So hopefully you're feeling around where your thumbs are. You're just feeling a little bounce. And you might even be feeling a little bit of engagement just at the bottom of that diamond. If you're not feeling it, don't worry about it. Just give me a polite cough. Just a little. If you weren't feeling it on the shh, you might feel it on this little polite cough. Great. And the best of all, just give me a little laugh, as real as it can be. Great. So them little bounces around this lovely diamond here, they are your kind of support muscles kicking in. They are supporting your breath. They are supporting the sound that is coming out of your mouth. And we often forget to use these muscles. So that's what I try and put forward through these sessions as well. We're going to make one more very loud noise before we get some singing done. So we've gone through the sigh, the twang, the whinge, and now we're going to shout. We're going to yell. But it's going to be really clean, like this. Shh, shh, hey! Shh, shh, hey! So it's that same little punch of air on the hey that you've used on them little short shh bursts. So let's try it together. Shh, shh, hey! Shh, shh, hey! Fantastic. So just really feeling that power there. Hopefully we've now all worked together to warm up our voices. You'll probably know that, or if you've ever been to a normal in inverted commas choir, you may have done things like la 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 la. I'm not really into that. I'm more into using your whole voice and lovely emotional sounds to get this sound out of our body. So I'm gonna have to mute you for the next bit. It's been lovely to hear some of you actually. We're gonna learn a little warm-up song that I do with movements called Hey Mr. Miller. So just repeat this line after me. It goes, hey, Mr. Miller, what a swing that you bring to the band. And again, hey, Mr. Miller, what a swing that you bring to the band. Let's do it again for luck. Hey, Mr. Miller, what a swing that you bring to the band. Hey, Mr. Miller, what a swing that you bring to the band. Lovely. Now it gets fun. With your trombone and your saxophone, you can hear it all over the land. With me. With your trombone and your saxophone, you can hear it all over a land. Again. With your trombone and your saxophone, you can hear it all over the land. First two sections done. One more. Ba ba dee ba 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 da 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 da. And again. Ba ba dee ba 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 da 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 da. One more time. Ba ba dee ba 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 da 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 da. Great. We're going to try it the whole way through. Don't worry if you've not grasped it yet. You still have time. So, as Natalie was saying earlier in the presentation, there's a big focus on the lovely out breath. Nice long phrases. So what I want you to try and do is, hey, Mr. Miller, what a swing that you bring to the band. So that would be one phrase. Let's try it together. 3, 4. Hey, Mr. Miller, what a swing that you bring to the band. And again. Hey, Mr. Miller, what a swing that you bring to the band. The next phrase is also in one go. So, with your trombone and your saxophone, you can hear it all over the land. Give that a go. With your trombone and your saxophone, you can hear it all over the land. And then the final phrase, some of you might recognise it from a bit of In the Mood. Ba ba dee ba 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 da 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 da. With me. Ba ba dee ba 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 da 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 da. Great stuff. So if you are finding them phrases too long, don't worry about it. Just do what you can. Get as far through that phrase as you can. They are there to challenge you. So we'll try the whole thing together, and then I'm going to make it slightly more difficult and fun. So here we go from the top. Hey, Mr. Miller, feel free to have a bit of a move and a bit of a click. 1, 2, 3. Hey, Mr. Miller, what a swing that you bring to the band. And again. Hey, Mr. Miller, what a swing that you bring to the band. With your trombone and your saxophone, you can hear it all over the land. With your trombone and your saxophone, you can hear it all over the land. Ba-ba-dee-bop, ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. Ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. Congratulations, you've learnt the first song. Bravo. So we are now going to work with virtual ed. So obviously I'm already virtual ed, but I have virtual ed that I recorded earlier. So you will be able to hear me, hopefully. It's going to sound like this. Hey, Mr. Miller, what a swing that you bring. Mr. Miller, so, what a swing that you bring to the band. With your trombone. But when virtual ed goes into with your trombone, that is when we are going to start with, hey, Mr. Miller. Follow me, and you will absolutely get it right. If you get it wrong, just find one of the other parts and sing a bit that you know. Loud and proud, wrong and strong. If you get it wrong, just go for it. All right, here we go. Hey, Mr. Miller. So we can have a bit of a rest here. I'm going to count you in. Hey, Mr. Miller, what a 1, 2, 1, 2, 3. With your hey, Mr. Miller, what a swing that you bring to the band. And again. With your hey, Mr. Miller, what a swing that you bring to the band. With your trombone and your saxophone, you can hear it all over the land. With your trombone and your saxophone, you can hear it all over the land. Ba-ba-dee-bop, with your ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. And again, with your ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. Hey, Mr. Miller. Hey, Mr. Miller, what a swing that you bring to the band. And again, with your hey, Mr. Miller, what a swing that you bring to the band. With your trombone and your saxophone, you can hear it all over the land. With your trombone and your saxophone, you can hear it all over the land. Ba-ba-dee-bop, with your ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. And again, with your ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da. And let's just 2 more of them. Ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. Really enjoy this last one. Ba-ba-dee-bop, bop, 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 ba-da-da-da-da-da-da-da-da-da. Bravo, everyone. Oh, you don't want to do it again. Woo. So that is typically the kind of warm-up song that I would do in a Singing for Lung Health session. I'm now going to bring another song into this that you might know a little bit better than Hey Mr. Miller. And it's from Oklahoma, called Oh What a Beautiful Morning. So I'm going to grab my guitar. So Natalie has control or has access to the chat here. And it might get lost somewhere in the ether of it all. But there will be some lyrics in the chat there in case you can find them. I am sure that you'll be able to get the hang of them anyway. There aren't loads and loads of lyrics in this. If you need to take a seat at any time, please do. I'm going to sit whilst we learn this. So whilst we're sat down, just make sure you have that lovely straight back and neck that we were talking about earlier on. So for those of you that don't know this tune, let's learn it together. It goes, oh, what a beautiful morning. Oh, what a beautiful day. Let's try that together now. Oh, what a beautiful morning. Oh, what a beautiful day. Great stuff. Then it goes, I've got a beautiful feeling, everything's going my way. Together, I've got a beautiful feeling, everything's going my way. So you will notice that I have joined a couple of lines together as a phrase. So, oh, what a beautiful morning, oh, what a beautiful day. Joining them 2 lines together. I've got a beautiful feeling, everything's going my way. So, if you weren't doing that last time, try your best to join them 2 phrases together. 1, 2, 3, 4. Oh, what a beautiful morning, oh, what a beautiful day. I've got a beautiful feeling, everything's going my way. Fantastic. So I haven't linked back yet to these lovely primal sounds that we were going over at the beginning. The whinge and the sigh and that lovely twang. So when you get up to that top note, especially any higher singers here, you've got, I've got a beautiful feeling, exactly what we did earlier with that twang. Whee! You want to channel that inner twang into this song. So, I've got a beautiful feeling. Even lower singers. I've got a beautiful feeling. Everything's going my way. So let's try that whole chorus together one more time just to make sure we've got it. 2, 3, 4. Oh, what a beautiful morning. Oh, what a beautiful day. Nice one. I've got a beautiful feeling. Everything's going my way. All right. So I'm going to take you through the verses now. Hopefully they are somewhere there for you to see. Otherwise, we'll learn them together. It goes like this. There's a bright golden haze on the meadow. There's a bright golden haze on the meadow. Let's try that together. There's a bright golden haze on the meadow. There's a bright golden haze on the meadow. The corn is as high as an elephant's side. Let's try it together. The corn is as high as an elephant's eye. Beautiful. And it looks like it's climbing clear up to the sky. With me? And it looks like it's climbing clear up to the sky. Great, I believe in you. Let's go for that whole verse. 1, 2, 3. There's a bright golden haze on the meadow. There's a bright golden haze on the meadow. The corn is as high as an elephant's eye. And it looks like it's climbing clear up to the sky. Here we go for that chorus. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. Right, second verse. I love this one. All the sounds of the earth are like music. All the sounds of the earth are like music. Let's do them 2 lines. All the sounds of the earth are like music. All the sounds of the earth are like music. The breeze is so busy it don't miss a tree. With me? The breeze is so busy it don't miss a tree. And an old weeping willow is laughing at me. That last line. And an old weeping willow is laughing at me. Great stuff. I think we've got it. Hopefully you all knew it before you came into this room, and if you didn't know it, it's been lovely to introduce you to a bit of Oklahoma. So please have a lovely stand for me if you are up for it. If you're staying seated, just make sure you keep that lovely straight back and neck, that lovely posture as much as you can. All right, so we're going to start with a lovely chorus. 1, 2, 3. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. Wonderful. There's a bright golden haze on the meadow. There's a bright golden haze on the meadow. The corn is as high as an elephant's eye. And it looks like it's climbing clear up to the sky. 4. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. All the sounds of the earth. All the sounds of the earth are like music. All the sounds of the earth are like music. The breeze is so busy it don't miss a tree, and an old weeping willow is laughing at me. Let's do this together, double chorus. Oh, what a beautiful morning, oh, what a beautiful day. I've got a beautiful feeling, everything's going my way. One more time, go for it. Oh, what a beautiful morning, oh, what a beautiful day. I've got a beautiful feeling, everything's going my way. Oh, what a beautiful day. Bravo, bravo, bravo. Oh, apologies for the unexpected ending in that one.
Nice for a bit of Feel Good Friday.
Yes, you've got to love a good bit of singing. If anyone's got any questions about singing for lung health, I'm more than happy to answer from my perspective, and I'm sure that Natalie might be able to add as well to some of them if anyone's got anything. Amazing.
I think you're the expert on the technical side of things.
Have we got time for me to do one more thing with you all? I think
we're here until
22.
22.
Yes.
I want to use the same chorus. And the one thing that I love to do is, as you could probably tell already, is to add a little bit of movement to the table. Because it's great for just releasing any tension that we might hold that gets in the way of our singing. All of these exercises that I've used with you today, I would use as a pro singer all the time. That's the main thing to remember. It is normal singing technique, but it works really well to help with breath support and breath control. So what I want you to try first is just moving your head from left to right as smoothly as you can. It doesn't have to be a nice big movement, just a little one. Great stuff. So now, a nice little challenge. Try and sing at the same time. So we've got, oh, what a beautiful morning, oh, what a beautiful day. I've got a beautiful feeling, everything's going my way. So that is your first movement. What I want you to do is, as we do these movements, just think about if it makes, if you feel like it made it easier for you to sing, or if it made it more difficult. Sometimes it does. Your next movement, I'm sure you'll enjoy this. One shoulder at a time. Just isolating that movement as much just to the shoulders as you can, so you don't want to be bringing your whole body into this. Just a nice raise and lift over of the shoulder. So let's try and sing it together. 1, 2, 3, 4. Oh, what a beautiful morning, oh, what a beautiful day. Yes. I've got a beautiful feeling, everything's going my way. So the last movement that I want to go through with you is a swing of the arms. So all of this is coming from your body. So you're moving from your hips, having nice loose knees, and your arms are feeling really heavy at the shoulders. Brilliant. So let's just try it with this. 1, 2, 3, 4. Oh, what a beautiful morning, oh, what a beautiful day. I've got a beautiful feeling, everything's going my way. Great stuff. So we're going to do a little exercise here. You're going to know this chorus by the end of this session, I promise you that. So the first time through, I just want you to sing it without any of the movements. Second time through, straight in with that lovely left and right of your head. Third time through, them lovely shoulders. And the fourth time with a swing of the arms. and just keep an eye on how easy it feels or how difficult it feels to sing alongside some of these movements. Okay, so without any movements, well, you can have a natural sway if you want. 2, 3, 4. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. Bring it in the head for me. 3, 4. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. And the shoulders. 2, 3, 4. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. The last one is the swing of the arms. Letting them arms feel nice and heavy. 2, 3, 4. Oh, what a beautiful morning. Oh, what a beautiful day. I've got a beautiful feeling. Everything's going my way. Great stuff. So if one of them felt particularly good for you, you're going to have that chorus in your head for the rest of the day, I can promise you. So when you're cooking dinner or going to the loo and you're singing that song, have a move of the head or a roll of the shoulders or a swing of the arms, especially if it felt good for you, and you're going to be releasing any tension or any holding patterns in that area where you might have felt a bit of release once you were moving about. I'm going to leave you with one little saying. Motion is lotion. A bit of movement always helps, especially with singing. And on that, I hope that I might see some of you in a Singing for Breathing group if you enjoyed it or you think it will be beneficial for you. There's loads of different groups on the BLF website as outlined earlier, and I'm biased, but I absolutely love it, and I hope you love it just as much. So.
Thanks very much, Ed. Rhiannon's just said in the chat that she didn't realise how stiff she was. So that's what I enjoy about joining some of the sessions in the week, is that when you're sat at a desk all day, you're tensed up and you don't realise how much tension you carry in your shoulders. And singing really helps relax all of these muscles up here. And also quite often when we sing, lots of people sing from up here in the chest, and it just pushes everything back down to here to where your muscles are working, which can help your whole body relax. So thank you so much, Ed. Really enjoyed that. And yeah, as mentioned, I just put a couple of links in the chat to the BLF, in particular the lung health support they have on there, and to the Breathe Arts Health Research website if you wanted to find out more about us.
Thanks, Ed and Natalie. We really appreciate it. I know Liz, our CEO, is really wants to get in touch with you about hopefully we can get becoming partnership and have like a singing class. So I'll get in touch with you about that. So maybe people can join for a Meso.
Thanks so much, Rachel. Thanks for having us, and thanks everyone for joining as well.
Thank you all. So what we can do now is when you leave this room, it'll go back to the main session. Lunch, like a lunch break started now from 12:40 until 1 o'clock, and then as 1 o'clock comes, we'll be starting back in the afternoon session. So thank you all for joining.
Thanks very much. Bye.
They focus on well-being and exercise programs and all of those kind of things that can help you live well. And managing things like pain is absolutely vital, but it is variable. And the same, some people never have any pain at all, and other people, you know, it's a feature from the start. That doesn't seem to be. It will be dependent on where the mesothelioma is. Lung cancer, just kind of slightly off track, but lung cancer isn't always painful because there aren't many nerves in the lungs, where the pleura is much more nerve rich. So that can be a bit of a symptom where if the mesothelioma, if the cancer starts to affect an area where there are nerves, and it's the same in the abdomen. It really does depend on where it is, but managing that pain is vital for the well-being of that person. It is variable. Just for a bit of background information, Pamelo's based in South Africa. She's a nurse in South Africa, and she managed to get to one of the conferences that we went to. And we're always delighted to see her. And she takes the information back to a very, very rural area of South Africa. And, you know, that kind of thing is just vital for the global treatment of these things. So absolutely, South Africa has a big population of mesothelioma, doesn't it, Pamela? Well, you're on mute. We can't hear you.
Especially our province, Northern Cape, where I stay. There were lots and lots of mines, even the informal mining operation where people used to generate income for copying and getting the asbestos product sold to the local businesses. You know, so many things happen, interesting and really painful for others because they were not aware that it might have a detrimental effect in their lives later. Thank you so much.
Yeah, no, that's lovely. Has anybody got anything else they want to ask? Otherwise, we could break a little bit early and have a little bit of a longer lunch break. These sessions are often, I don't know about you, but usually by the end of the morning, I'm ready for a little bit of a break away from the screen. But has anybody got anything else they'd like to ask? No? Okay. Well, I'll close down for now. I'm going to send out a reminder about the peritoneal support group meeting. I'll send that out on Monday with the link. And I appreciate that my knowledge isn't as great as Sam's. I do understand that. But if you do want to come on that call, please do. And anything I don't know, I will find out for you afterwards. But my email address went into the chat box. Don't be afraid to contact me. And again, I'll find out the answers for you. I do have a contact in the Basingstoke team while Sam's away. So go and have some lunch and a drink, and we'll welcome you back later on. Let's see, what time's that session starting?
Thank you, Anne. It's Rachel now. They
hello,
have to
Rachel.
leave.
What time are we back?
So the next session, we're back at 1 o'clock.
1 o'clock.
So you've got 10 minutes.
Lovely. Okay. They're due to close in 2 minutes anyway, so we're only 2 minutes ahead. I will see you back at 1 o'clock.
Thank you. Bye.
Thank you. Thank you for joining. Bye.
Hello, good afternoon. Welcome back. I hope you've all had a chance to grab something to eat. For those of you who weren't here this morning, my name is Carolyn McRae and I'm a Mesothelioma UK CNS. I'm based in Glasgow and cover the west of Scotland, and I'm the CNS team lead for Scotland. Joining me this afternoon for chairing duties is my colleague Leah Taylor.
Hello everyone, my name is Leah Taylor. I'm a mesothelioma nurse specialist based in the northeast of England, and I'm the team leader for the north of England. So for this next session, we have had a slight alteration from our programme, and we're just going to move the session with Dr. Barbara Murray back a little bit. So this session is an interview with Nigel Shaddock and Lucy Haycock, and we're very thankful to Hugh James for sponsoring this session. Nigel is 53, he lives in Inverness, but he's originally from Bedfordshire. His day job is maintaining mobile phone mast and infrastructure throughout the Highlands and Islands. And for the last 10 years, he's been a keen competitor in endurance sports, taking part in many Ironman triathlons and ultra marathons. So thank you, Nigel and Lucy.
Oh, hello, thank you for that introduction. I'd like to start by saying how grateful I am to have been given this chance to meet up with Nigel again for this session. If you attended the last Meso Day, you'll know I'm a bit of a fan and a bit in awe. Nigel is an endurance athlete, having done many awesome, crazy events, such as Ironman events. He's very recently completed the grueling Starman triathlon, starting at midnight, I think, with a 2-kilometre swim at Glenlochmorlich, 90-kilometre cycle, topped off with a half a marathon over Cairngorm Mountains. Phew. But I'm also a bit of a fan because of the amazing way he's dealt with his diagnosis and subsequent work, raising awareness of mesothelioma, campaigning, and also supporting others. Nigel, I'm guessing that there may be many here today who will know you or of you and what you've come through in the last few years. I first met you when you were diagnosed many years ago when you came to your first oncology clinic. And I remember being struck by your calm and positive attitude from the word go. I'm sure it belied a pretty harrowing time for you and your family. It's so fantastic to see how well you are now. But back then your future must have seemed so very different. And maybe you could tell us a little bit about that period of becoming unwell and being diagnosed.
Oh, Lucy, thanks very much for the kind introduction. Likewise, I'm a huge fan of you as well. It was a tough time for me and my wife. It really was. I always liken it to like falling down a well and there's no one to catch you. You just seem to get news, then the news gets worse. You get the prognosis. That's pretty bad. There's just no help. It just felt like I was just dropping and there was no one there to save us. Yeah, it was a tough time. We probably given about 12 to 18 months prognosis, I think. At the time, there wasn't much in the way of treatment either.
Mm-hmm. Yeah, and did you know what mesothelioma was? I think sometimes we have people coming and they've never even heard of it, and so you're sort of even grappling with that to begin with.
No, not at all. I think my friend Paul sort of he says it sounds like a Greek cheese or something, you know, not a clue, you know. It's like
no,
I've never even considered that I'd had any exposure to asbestos. You know, it's I mean, I've done a lot of asbestos awareness stuff in my work, but the word mesothelioma never came up.
No, so, and were you able to identify any exposure that you'd had to asbestos?
Well, you think when I first got diagnosed, that one of the notable things was I seemed to have a lot of solicitors on my case wanting to prosecute anybody, but there's no one I could point a finger at and go after. You know, when you think back, there could have been so many different exposures. To do it truthfully, it's hard to say. I was brought up next to a youth hut, a scout hut, which was made of asbestos. In fact, my boy bedroom window backed onto this hut. I kind of lived in that most of the time. I'm a keen motor enthusiast, so I was probably exposed to brake asbestos and clash asbestos. But in my work period, I used to, when I was an apprentice, I used to work for a company that worked for the Royal Navy on communication equipment. So I was always sort of blown away dust off bits of electrical equipment and stuff like that. So maybe that.
Was it, and has that been difficult, not being able to pinpoint that or looking for it, or do you spend a lot of time sort of thinking about it?
No, not at all. I think my main focus was on moving forward. It's like I was saying, we were falling and just felt like we're going backwards. And to me, looking for someone to go after, to sue and get compensation, it wasn't really anything important for me. You know, it was
not the focus.
In fact, it became annoying having to go back to think about that a lot. You know, so
yeah,
I just totally put that to the back of my mind.
And, that's really interesting.
On getting well.
Yeah,
for sure.
Yeah. And having done so well, when you talked about being given a sort of a prognosis, does that, looking back, does that make you feel angry or upset because you've done so well and it was?
Yeah, I think the problem is when clinicians give a prognosis, they're looking at statistics, and statistics can be read in so many different ways.
Yeah.
And there's so many things to take into account. You've got to take into account people's lifestyle, their age, how they react to drugs, how they react to illnesses. There's so many things. So just to say, right, that's 12 months. That's that's not very helpful, really.
No.
Yeah.
No.
Absolutely.
Big thing. And I think you looked into trials. You took a very sort of straightforward go. I remember just absolutely, well, what can I find out? What can I do? And to help. And I think it always felt that you had done the work looking into trials. And how easy was that, or difficult, or was it frustrating that you felt you had to do it yourself? Or
not at all. It's not. It's difficult until you find a lady called Mavis Nye, and when you find Mavis, things do become a lot easier.
Yes.
So,
yeah.
No, I wouldn't say it was difficult. It was kind of, I hadn't realised at the time you had to take these sort of things on yourself. I kind of assumed that would be all sorted out. Where I live in North Scotland, in Inverness, there's nobody doing trials into mesothelioma. And we're quite a remote sort of town stuck up there in North Scotland. And I really don't think people thought I would be able to or want to travel to Edinburgh or Glasgow or even to England to get treatment. I mean, at the time, I was even looking at living in America. I've got a cousin who lives in Washington, D.C., and there's a lot of research there. I mean, that was an option for me as well. I think a lot of clinicians need to understand that when you're given a prognosis like that, you're going to pretty much do anything to do what's best for yourself and your family.
Yeah, and I think looking back, I think there was a bit of misconception sometimes that I think in days gone by, slightly assumptions made about what people would want to do and how far they'd want to travel. And I'm hoping that's all changing quite a bit these days. And I think sort of days like today sort of reflect that, and there's access to trials. So I'm hoping that is absolutely better. Can you tell us a wee bit about the trial and what that was like? Because that did involve 2 weekly travelling suddenly to Edinburgh. And did it feel like a gamble going into a trial, or? No,
not at all. I think you don't take the only gamble is when you get randomised and which arm of the trial you're going to get. But and looking back on it, who knows that immunotherapy was a better option for me than chemotherapy. There's so I mean, I was delighted to get the immunotherapy arm of the trial, but at the time, who knows if that was any good for me. I was looking to get in the surgical trial. I think it was the Mars 2 trial, but by the time I'd looked into trials and found looked at these options, the disease had progressed too far, so that option had been taken away from me. But no, my trial was with Bristol Myers Squibb, the Optivo trial, Checkmate 743. It was two weekly, an infusion every 2 weeks at Edinburgh Hospital. For me, that's a 3-hour drive to Edinburgh, sit in a chair for a couple of hours, and then a 3-hour drive home. It really wasn't that bad, and the staff were great at Edinburgh. It was good for me. It worked out really well. The drug company are quite help out with travel expenses, and and that, you know, it was, you know, overnight accommodation if you needed it. Yeah,
Oh,
and
good.
you know what was nice? It was actually nice was having a routine, you know, of actually like, because before I was on a watch and wait policy, but it was actually nice for the first time to like felt like he was in charge and doing something, you know.
Absolutely. And I think a lot of people find that, especially when and possibly when treatment stops for whatever reason it is, sometimes just the course comes to an end, or people get side effects, or it stops working, they have to stop. And I think that can be a real difficult time for people when they're sort of being on treatment is a sort of safety net, isn't it? You feel that you're doing something.
It was for me. When I came off the trial, it was quite a shock, you know, because I felt quite safe after having the treatment every 2 weeks. To go from that from nothing was quite scary.
Yes, I'm sure. And then you're left with all that scan anxiety, aren't you? Sort of every few
still
months.
Have it, Lucy. Yeah.
I don't know how.
3 monthly scans.
Yes. Yeah. And how do you deal with that, or do you have any suggestions? Yeah.
No, I every 3 months I come up with a different strategy, and it doesn't work. So, I try to ignore it. I try to be busy. You know, I just try everything, but every time, about 2 days before the scan, I start to get chest pains, and those chest pains don't really stop until I get the scan results. Just brought on anxiety. And every month, every 3 months, the pains are completely different, but all in the same area.
All in the same, and it's such a common, normal thing, and I think everyone recognises it, but I think we failed to find a sort of solution to that. But,
absolutely, yeah. So I've just had my last scan last week, so I've got another 3 months now. So woohoo!
Good, and it was good. So that's excellent. So So you talked a little bit right at the beginning, just that whole impact of the diagnosis on you and on your family. Sometimes we focus quite rightly very much on the patient, but I think for clinicians and things, I think it's very important for us to know that the impact that it has on sort of family and everyone around you. Can you maybe talk a little bit about, you might not want to, but just how you've dealt with it, with your, you know, with sort of family and loved ones, and sort of maybe what's helped and what hasn't helped, or.
I think from my point of view, you definitely need help. You know, I so needed help. I just looking after and support. You know, I was so having that other I think the main problem is you can't focus properly, and you need someone else with you to sort of point out the realities of things. You know, the practicalities even. Because your mind's just a mess. You just can't just cope with just normal things, you know. I mean, it is tough on loved ones as well, and it's it's quite difficult. You end up feeling quite selfish because you get a bit self-absorbed with the whole cancer thing, and you know, you have to remember there are other things apart from cancer, you know, and life has to go on.
Yeah, but not easy. And did you specifically, of clearly Mavis, but what resources do you think that you used, or even family used, or what would you sort of recommend if you had found anything that was more useful?
Yeah, I mean, I for me, it's Facebook. Really, it's you know, some people hate Facebook. I've got friends with different cancer diagnoses, they just won't go anywhere near Facebook. But for me, Facebook was a massive tool for me. It was brilliant. It was such a community on there, and get to talk to other people, especially like meeting Mavis. And then you can actually meet people that are doing well, you know, just didn't live for 12 months, you know, are having normal lives, and real people out there doing things. It gives you so much hope, but not just normal hope, but real hope. It really does. And I've met so many friends. I've got a really good friend now, Paul Cook, who runs Erase Meso, an absolutely inspirational guy. You know, I mean, me and Paul cycled Land's End to John O'Groats in 2019, raising money for meso awareness. It's fantastic. And none of that would have happened without Facebook.
No, it connects you up and gives you all those access to people. So I mean, do you want to tell us anything more about Action Meso, or
well, Paul and I Well, but Paul is great. Paul is a real inspirational, go-getting sort of guy. I sort of follow him around really. Paul and I, we just done the NC 500 cycle tour this summer. So we've done Land's End to John O'Groats, and it's Paul's mission to find it's to find a cure for mesothelioma, and I'm pretty sure he'll do it. I'm convinced he will do it.
Probably will. So
yeah.
And I think I always like to think that something like today and being able to speak to you is a chance for you to let us know and other people that are listening. So with all the, I think we'd all like to thank you for all that raising awareness and for mesothelioma and trials and things. It must get a little bit tiresome always asked to things like that, but we really appreciate it. But if you had any sort of key messages for other people facing mesothelioma or cares, are there any things that you suggest that's helped you, or what you think's important? Or I don't know how you can sum all that up in it's a bit
well
question,
for me, yeah. for me, it was all about trying to live the healthiest lifestyle you possibly could. That's physically and mentally, so I totally looked at my diet and thought, right, I'm just going to go for like a multicolored vegetable based diet and I'm sure that helped me. I go for all the vitamins. I'm not sure if it's working or not. I do the turmeric and the turkey tails, but I don't really want to not stop doing it because I feel like I'm doing quite well. And I think that one of the main things mentally is you just got to surround yourself with positive people, and just don't get into arguments and negativity. That certainly works for me.
You've done well with that. So, and any messages for clinicians? I mean, is there anything that we need to think more about, or that you would I mean, I think you sort of suggested about trials.
Just don't make assumptions born out of statistics. It's really not very helpful. I think you've got to take everyone at their own value, and maybe. I think things have changed now, Lucy. To be honest with you, I think there's so much more emphasis on trials, which is better. But I think we need to be telling patients that there are people that are doing well, and it's not just me. There's lots of people that are doing really well, and I think we need to tell our patients that for sure. It'd be brilliant.
And I don't think we can overestimate how important it is for us to hear from you and other patients in forums like this, and it keeps us really grounded, I think, in our job. So I'd really like to thank you for taking time today. And it's really important. Well, it's really important. I know that others affected by mesothelioma are really, the patient's family, really grateful for the support. And I know on a personal and support groups and other levels, how important that has been to people. And I used to hear that in my job. People used to talk about you. So I think we're very, very grateful. I'm sure there's going to be lots of questions at the end of the session for you. I can't sign off. Well, before I sign off, is there anything else particularly that you feel you would like to mention, or that we haven't covered, that you'd like to get across today? Or
no, Lisa, I think we've done everything. I'm quite happy to take any questions. That would be good. And thank you for doing this interview. You're a really good interviewer, Lucy. You put me at ease. I appreciate this.
No.
But give up your day job. You've got another job.
And I can't sign off before finding out what your next escapade is. What madness you're up to.
Well, it's coming. The year's coming to a close now, so we've done lots of different big events. I was just getting a bit more back into the mountains and hill walking. I'm enjoying that at the moment.
Oh, lovely.
I've got 2 more triathlons to do. One next weekend, and I think I'm joining you, Lucy, aren't I, in Craggy Island?
I think I'm going to be seeing you at Craggy. Yes.
Brilliant. Looking forward to that.
So that'd be good. That'd be good.
Yeah.
I think you're doing it in the big boys' day, but so.
Oh, I don't.
Right. Well. Nigel, thank you. It's lovely, and it's so fantastic to just see you looking so well. And it's been great. Great catching up today. Thank you.
Okay.
Yes. Bye bye.
Thank you, Nigel, and thank you, Lucy. Just a reminder that you can continue to post your questions in the chat function. Nigel will be joining our panel later, and you can put your questions to him if you have any. Also, just to remind you or to let you know that we're active on Twitter, and the Twitter handle for this event is #PCD2021 or hashtag Meso Patient Carer Day. If you're so inclined, you can do that. In another change to the programmed agenda, we're going to move on now to hear an update of the research that's going on at the Mesothelioma UK Research Centre. Dr. Claire Gardner will be presenting, and this is sponsored by Thomson's. Claire is Vice Chancellor's Fellow undertaking the fellowship project on the cost of palliative care in the last 6 months of life. She previously worked as a senior lecturer at the University of Auckland, New Zealand, before which she was a lecturer and research fellow at the University of Sheffield. Claire's been involved in palliative and end-of-life care research for over 8 years and has been published in over 50 papers in peer-reviewed journals. She's also been involved in a number of international research projects totalling over £3 million of funding to date. So we are very grateful that Claire has given her time to provide this session for us. Thank you.
Hi everyone. It's really great to be here talking to you all today and telling you a little bit about what we've been doing at the Mesothelioma UK Research Centre over the last 12 months. My name's Claire Gardner, and I'll be talking through this session over the next 20 minutes. So for those of you that don't know, the Mesothelioma UK Research Centre was established last year in July 2020 is when we opened our doors. And we're based at the University of Sheffield in the Health Sciences School in the Division of Nursing and Midwifery. And of course, we're very generously funded by Mesothelioma UK. So I just wanted to start off by telling you a little bit about what our vision was for the Research Centre and really what we want to achieve over the 3 years that our Research Centre, the 3-year cycle of the Research Centre. So I think it goes without saying that we want to conduct research that is robust and rigorous and of course with a reputation for excellence. But I think the number one priority for us is really that our research is of benefit to people with mesothelioma and their families. And the main focus of the research that we do at the Research Centre is around patient and carer experience of mesothelioma. And of course, within that, there's lots of different pieces of research that we do, and I'll come to tell you a little bit about the individual projects a bit later on. But as I've said, our fundamental priority is really to make sure that the research that we do benefits people with mesothelioma and their families. So this is the team at the Mesothelioma Research Centre. Myself and Angela Todd are joint directors, co-directors of the centre. Many of you will know Angela Todd, I'm sure. She's been involved in mesothelioma research for many years and has a huge amount of expertise in the area. My background is in palliative and end-of-life care, and that's an area that I've been working in for the past 10 or 12 years now. And we are very ably supported indeed by a fantastic team of postdoctoral researchers who we work with at the university, who lead on individual projects within the Research Centre. We also have 2 PhD students, Virginia and Emily, and I'll tell you a little bit about their PhD projects a bit later on. We have a coordinator, Angela, and some honorary staff who work with us, Peter and Matt. We're also supported by 2 fantastic panels, an advisory panel, which is made up of experts in mesothelioma, and then our patient and public involvement panel. And we're very lucky and we're very grateful really for the expertise that we have to be able to advise us as we undertake the research in the Research Centre. You can see this little photo on the right here of one of our team meetings. When we established the centre last year, obviously July 2020 was in the real midst of the COVID pandemic, and this is how we've been conducting all of our meetings, and all of our research has been online like this, you know, sat at home looking at our screens. And I think it's a real testament to the commitment of the whole team, how successful we've been in our first year, despite some of the challenges of COVID and remote ways of working. So as I mentioned, we have two PhD students, Virginia and Emily. Virginia's PhD is on care needs of family carers of armed forces veterans, a really fascinating PhD study. Virginia's coming towards the end of her study now, and as I said, she's identified some really interesting findings. She published a paper last year, which was a review of the literature. So if this is a topic you're interested in, then please do have a look at Virginia's paper. Virginia will hopefully be publishing some more of her findings over the next few months. Emily is our other PhD student. Emily is a GP by background, and she's just coming to the end of her first year of her PhD. And her PhD is around continuity of care in primary care. So that's care delivered by GPs and in the community, and looking at how we can improve continuity of care for people with mesothelioma. So that's really making sure that people have joined up care and that there's no gaps in the care that people receive, particularly in the community and in primary care. So two really interesting studies, and if anybody's interested in learning more about those or wants to chat to either Virginia or Emily about their studies, then have a look on our website and their contact details are on there. So before I tell you about what we've been doing over the last year, I just wanted to reflect back a little bit further and tell you about some of our completed studies that were undertaken previously to the research centre being established last year. As I mentioned, Angela and some of our other colleagues in the department have been working on mesothelioma research for many years, and these are studies that Angela and her colleagues have led. Most of these studies are now at the point of completion, but we're starting to see some really nice impact from now, and we're starting to see how this research can actually go on to benefit people with mesothelioma. The MIND study, I'm sure some of you have heard of, was about experiences of mesothelioma in the military, and that research contributed to an award that was a very prestigious award that was given to Mesothelioma UK from the HSJ, and we were really delighted that our research played a small part in Mesothelioma UK receiving that really prestigious award. The MAG study was a study looking at mesothelioma in healthcare staff. Again, that study has now come to completion, but we've been able to publish some guidelines from that study, and those guidelines are now being rolled out and being taken up by NHS trusts in the UK. Similarly, with the radio meso study, that was looking at how a diagnosis of mesothelioma is communicated. And obviously that can be a really, really challenging time in the mesothelioma pathway. And one of the outputs of that study was some guidance for how to deliver a diagnosis of mesothelioma. And those guidelines are now being rolled out into clinical practice and adopted. And then finally, the GEMS study, which looked at gender and mesothelioma and looked at the different experiences of men and women and looked at any differences really in how they experience mesothelioma. Again, that study has just come to completion, and we've just produced a really nice short animation which tells you about the findings from that study. It's only a couple of minutes long. If you would like to see the animation, please have a look on our website or on our Twitter account, and you can see the animation there. That's being shared far and wide, which is really nice to see. Again, some impact coming from our research. So as I said, those are projects really that preceded the start of the research centre, but over the last 12 months since we opened our doors, we've been working on a variety of different projects, and this here tells you about some of the work that we've been doing over the last 12 months. I'm not going to tell you about each one of these studies on their own. I haven't got time today, unfortunately. But if you're interested in any of these projects in particular, again, have a look on our website, and there's more information there about each of these individual studies. As you can see, we're working on a really wide variety of different topics within the area of patient and care experience in mesothelioma, and covering lots of different areas of work. The research prioritisation exercise is probably our main piece of work over the last 12 months, and I will tell you about that in a little bit more detail next. So the research prioritisation exercise, as I said, that's the sort of the biggest bit of work we've been working on over the last 12 months. And the aim of that was really to try and identify what are the unanswered questions about mesothelioma patient and carer experience. What are the research priorities? What are the things that we don't know? And of course, we need to know that information in order to inform the research that we go on to do over the 3-year cycle of the research centre. So we felt this was a really important first piece of work for us to try and identify what are the unanswered things, the things we don't know about mesothelioma. And we used a systematic research process for that, something called a consensus exercise. And there was 4 steps in that, which you can see here. So the first step was an evidence synthesis. And that was basically just looking at what's been done already, what's been published already in the academic journals, what do we know about mesothelioma, and where are the gaps. The second stage of that research, which was probably the biggest and most important stage, was a survey. So we wanted to get input from around about 100 respondents, and we wanted to get input from people who have experience of mesothelioma, either as a patient or a family member, or as somebody who works as a health professional or in another capacity who have expertise in mesothelioma. We developed an online survey, and we sent that out far and wide into the mesothelioma community, and really just asked people to tell us, what do you think are the main priorities in mesothelioma? What should we be looking at? Where should we be focusing our research attentions? And then the third stage was working with a smaller group who we called a steering group of experts, and trying to rank some of those research ideas or unanswered questions that we'd identified from the survey. And then the final stage was, which we're just sort of coming up to now, is us generating a list of around about 10 research priorities for mesothelioma. So as I said, the main part of this piece of work was our survey. We had an online survey, and we sent it out throughout the mesothelioma community and asked people to respond. We'd aimed for about 100 responses, and we were absolutely delighted to get well more than that, and got 150 respondents, which was absolutely fantastic. And I'm sure there's many of you out there in the audience who are listening to this who completed the survey, and we want to say a huge thank you really to everybody who was involved, either by completing the survey themselves or by sharing it on social media or sending it out to friends and family. So a big thank you to everybody. We were also really, really pleased that when we looked at the different respondents to our survey, we found that well over half of the people who responded were people with mesothelioma or family members or friends of people with mesothelioma. And that was really important to us. We really wanted to make sure that the research priorities that we identified were really derived from the needs of patients and their family members. So we're really pleased that we got such a great response from patients and their families. The other people who responded to our survey were healthcare professionals, asbestos support groups, lawyers, and then other professionals, volunteers, and academics. We were also really pleased to get a really nice geographical spread in terms of the people who responded to the survey. This is where all the respondents came from in the UK. So as you can see, we had a really good spread across the different 4 countries of the UK, which was really nice. And we felt that we had a really good representative sample of people with experience of mesothelioma. So this is our exciting findings that we derived from the survey. So we collected all this data from 150 people, we brought it all together, and we drilled it down into these list of research priorities for mesothelioma. As you can see, there's a number of different areas here that have been highlighted to us. And I suppose some of these areas we weren't surprised to see in our list of top priorities, certainly things like symptom management and treatments and care delivery we would have expected to see. But then some other things in here as well that perhaps were more surprising, certainly palliative and end-of-life care. Perhaps that's something that we don't talk about so much in mesothelioma, but that was really highlighted as a priority. And things like peritoneal mesothelioma, obviously one of the rarer types of mesothelioma, but again, something that was really highlighted as being important. So after we'd collected that initial list of priorities, we worked with our steering group and asked them to rank these different areas of research and tell us which they thought were the most important and which were the least important, so that we could help us inform the research that we do as we go forward. So we generated this graph here. You don't need to worry too much about the percentages along the bottom, but what really this tells us is those topics with a more dark blue, those were thought to be higher priority or higher ranking, and those topics with more light blue were ones that came lower down in that ranking exercise. So you can see that particularly treatments and symptom management were very highly ranked and thought to be really, really important, and then perhaps compensation, at the other end, one of the lower ranked topics. So we also identified some topics that came through in our survey that people told us about and people thought were very important, but we decided that they weren't within the scope of our particular exercise. As I mentioned, the focus of this exercise was looking at research priorities that were related to patient and carer experience in mesothelioma. And there were some issues that people brought up that we completely acknowledge are very, very important, but don't come within the scope of what we were doing. And those were largely issues around looking at sort of molecular level and cellular level pathways in mesothelioma, and then also, of course, research into treatments and research into finding a cure. Hugely important issues, and we just wanted to acknowledge that these are hugely important areas for research, but within the scope of our research prioritisation exercise, we focused more on the patient experience topics. So at the end of this exercise, after working with our steering group and taking the survey responses and doing our ranking exercise, this is what we've come up with as our top 5 research priorities. And originally we'd hoped, I think, to be able to put these in order and sort of say which, 1, 2, 3, 4, 5, which are the most and least important. But after having a lot of discussion about it, it was decided that all of these topics actually have equal priority, and they're all really important and all really need addressing. So these are in no particular order, but these 5 priorities are really our top research priorities. So symptom management, not surprisingly, and that's not just physical symptoms, but psychological symptoms as well. Receiving a mesothelioma diagnosis, as I said earlier, a really challenging time in the mesothelioma pathway. Palliative and end-of-life care, and by palliative and end-of-life care, we're not just talking about the very end of life, the last few days or weeks of life, but actually quality of life across the patient pathway, right from the point of diagnosis sometimes to the end of life, and of course supporting people in bereavement. Experience of treatments, so looking at the impact of treatments, and also exploring what sort of factors influence treatment decisions. So what sort of factors influence whether or not somebody decides to take on a particular treatment. And then finally, barriers and facilitators to joined up service provision. So how different health and social care professionals work together to meet the needs of people with mesothelioma. So that was our top 5 priorities. We had a further 6 priorities that, again, we felt were very, very important. These are slightly less of a priority than those top 5. So we have sort of two sets of priorities, if you like, the very high priority and then the high priority, which is these 5 you can see here. So again, you can see these 6 different research priorities, all very clearly derived from that information that we collected from the survey from the mesothelioma community. So what next for our research prioritisation exercise? We've got a little bit more work to do on our final list of priorities. We think we're pretty much there, but we've got a little bit more work to do on that. When that's finished, we're going to publish our Statement of Mesothelioma Research Priorities, and that will be available on our website, and we'll obviously share it on our social media accounts as well. Once we've published that, that Statement of Research Priorities, that's really only the start for us, because that's going to be the document that helps inform all of the rest of the research that we do in the research centre. We also want it to be used widely across the research community, and we want it to be a useful document for other people doing research in mesothelioma. So please, when that's published, share it far and wide as much as you can, because we want people to make use of it when it's published, and we want other people to be able to make sure the research that they're doing is really sort of meeting the top priorities in mesothelioma research. So I just wanted to finish off by briefly telling you about some of the other things we've been up to at the Research Centre over the last 12 months. As I mentioned, we're supported by a patient and public involvement panel, or a PPI panel, and that panel is made up of people who have personal experience of mesothelioma, either as a patient or a family member or a friend. And that panel works with us on all of our different research studies, advising us and providing us with guidance. If anybody's interested in joining the PPI panel, then please do look on our website. There's a page on our website with information about the panel and how you can join, so please do have a look. We're always keen to welcome new members. And I just wanted to finish off by telling you about some of the successes we've had really with outputs and publications over our first 12 months. I apologise, that slide might be a little too small for you to actually read those individual papers, but I just wanted to say we've been really successful in publishing our work in academic journals, but also presenting our work at some of the really big national and international conferences in mesothelioma as well. We were really pleased to present a number of our pieces of work at IMIG, which is the International Mesothelioma Interest Group, and I think we were represented on 12 different abstracts to that conference, which is really fantastic achievement for the research centre. And of course, it's not just about publishing our work in academic journals and in peer-reviewed journals. We really recognise that there's other very important ways to disseminate our work and other important ways to have impact. And this just gives you an idea of some of the other things that we've been doing with regards to some of our key outputs and impacts. We've had a lot of media interest in the research centre, particularly around our launch, which was great. Interviews in the radio and featured in newspapers. So it's really nice to see that clearly there's a wider sort of public understanding that research in mesothelioma is important and necessary. Similarly, we've been fortunate to have some great engagement at a parliamentary level. We've been able to contribute to parliamentary select committee inquiries, have questions asked in Parliament on our behalf, and have some engagement from the House of Lords. So I'm not going to carry on too much longer because I'm aware my time is coming to an end. But I just wanted to finish off by letting you have our contact details. I've mentioned a few times our website, which is a source of most of our information about our projects and what we do and how to contact us. So please do have a look on our website. You can also sign up there to receive our regular newsletters, which we send out every couple of months, which tell you regular updates about what we're up to. Similarly, please follow us on Twitter. And if you want to get in touch, then here's our email address, or individual email addresses are on our website. Thank you very much.
Research Centre, absolutely fantastic to hear. If you would like to participate in any of the work going on in Sheffield, please do get in touch with the team there. So for our next session, say thanks to Field Fisher for sponsoring our next session, and I'm delighted to welcome Dr. Barbara Murray to talk about making the most of your palliative care team. Barbara is a general practitioner in Stockport in a very busy practice. She's been fortunate to have 2 successful careers. Her first as a biomedical scientist, specialising in haematology and blood transfusion serology. Barbara has also been extremely lucky to have been asked to participate in a number of TV programmes for the BBC and other channels, as well as Radio 5. So I'm really pleased to hear from Dr. Barbara Murray. Thank you.
Hello. I hope you can all hear me. Just a bit of an update on my current status. I've retired from general practice a couple of years ago, and I now work as a palliative care specialty doctor. I still maintain my GP contacts and still consider myself as a GP with a special interest in palliative care. I've been asked to talk today about making the most of your palliative care team, and I approach this from several angles. First of all, as my experience as a GP and working in the community, and as the palliative care lead in my practice, now also as a hospice doctor, but also my personal experience as a carer for my mum, who passed away not so long ago at the age of 97. And I had the strange experience of having to rely on help from the palliative care team myself, which I resisted for a while, but I'm so glad I did involve them. So I do feel as though I've had a lot of experience from a number of different angles. What we need to ask ourselves, first of all, is what is palliative care? Because I will go through the sort of myths and facts about palliative care. But palliative care really is specialised medical care that focuses on the various symptoms that are associated with complex illnesses. And it does not mean that we have reached the end of life. It's a stage in life and stage in disease that requires a different approach. And I know this from working at the hospice, seeing people who've been attending the hospice for many years alongside receiving their other standard treatments such as chemotherapy or radiotherapy, but having the palliative care alongside that. So next slide, please. So palliative care teams are made up of different healthcare professionals. So each group of people coordinate the care for people with, I'm saying here, incurable illness, but who knows? Just people who have got either a progressive illness or a chronic illness that requires that sort of focus. There are specialists in palliative care who advise other professionals on how to treat somebody who requires palliative care. So often the consultants in the hospice will also do a ward round in the hospital and advise a specialist there what's the best approach for different types of symptoms, whether it's pain, nausea, vomiting, even constipation, and breathlessness. Next slide, please. So in the community, so speaking as a GP, for example, if you're being cared for in the community, then your GP has the overall responsibility for your care, and the hospital doctor will write to your GP with the advice of how to progress with the care in the community. And that would apply even if you were in a care home, for example. The community team will consist of district nurses, Macmillan nurses, the community palliative care team, which will be headed by the consultant who works in the hospice and the hospital, and also the specialist nurses, all working together to coordinate the care. So I've debated whether I should discuss this with you, but I'm thinking that it might be helpful to just give you a sort of resume of how things worked in my own experience with my mum. My mum was at home and she died at home with the care from the community palliative care team. And it was the most beautiful and peaceful end to the life of a 97-year-old who was suffering with breathlessness. And so I feel it's quite relevant to what we're talking about today. My mum was a very stoical lady, still going to Tesco's up until a couple of months ago, apart from being restricted by the pandemic. And she just became increasingly more breathless. She refused to go to hospital, and she thought that because I was a doctor, I would be able to deal with everything. And she had every faith in me, which was good, but I struggled myself because of the emotional side of things. And we got to a point where I needed to ask the GP for help. And the GP came out and prescribed oral morphine. My mum only needed a small amount of it and a small spoonful, and it helped her with her breathing. And then towards the end, the district nurses came out and gave her the odd injection just to ease her agitation. And it could not have been better care. And the help I got helped me to feel safe and also reassured me that I was doing the right thing in enabling my mum to be at home and not be at the hospice, because that was her wish. In the hospital, there are doctors and nurses who perform the same function as the doctors and nurses do in the hospice. Obviously, when you go into the hospital, it's more medicalised. So there will be x-rays and blood tests and all of the things that go along with maintaining the hospital care in the way that the approach that we have in the hospital. But once it's decided that all of those very active, invasive forms of treatment are no longer advisable, or you decide yourself that you just don't want to proceed with that, then the palliative care team will step in and take over. And that does not mean it's the end of everything, and it doesn't mean that you can't go back. I mean, for example, in the hospice, we'll admit people for hospice care, palliative care, but they'll still go for scans, they'll still have x-rays, they'll still have intravenous treatment, fluids, antibiotics, all of those things. But the things that you perhaps associate with the hospital, like having major surgery and those sort of things, we probably would not consider, because a patient has decided they don't want that anymore. If you're being cared for at home or in a care home, the GP will coordinate that care and will take responsibility. And I, as a GP, have promised my patients many a time that I will care for them right to the end. And I've even returned home early from a holiday to make sure that I keep that promise. But in the hospice or in the hospital, you will have help from other people in the palliative care team, such as physiotherapists, other forms of therapists, art therapy, for example, the acupuncture that is sometimes available to people, the complementary therapies such as Reiki and aromatherapy, but also access to counselling, psychotherapy, the chaplain for all faiths or none. And believe me, the chaplain that I know, he's not religious at all, which is a strange thing to say, but he always manages to find the right words. So it's extremely comforting for all of us who need that help in times of difficulty and stress, and not necessarily at the end of our lives. Next slide, please. This team I work with at the hospice, and they're part of the day therapy team. So if you're offered daycare or day therapy, please may I suggest that you go along with that, because at the moment we're running sort of the face-to-face online sessions, but when the pandemic, before the pandemic existed, we could invite people into the hospice, and this team are still operating on that level, but over the internet, a bit like this. And amongst those people, we've got counsellors, the ancillary staff, the cleaners, domestic staff, receptionists, fundraisers, all of the people involved in the hospice care. I promise you, each and every one of them is some form of an angel. They're hilarious, they're uplifting, they're full of enthusiasm. It's not a place of despair or misery. In fact, I see it as therapy. For me, when I go there, I'm uplifted by the positivity in that team. So if anybody does suggest to you that you go for daycare, then please take them up on it, because there's so many different aspects to it. It's entertainment, quizzes, there's creative therapy, there's all the different things that you might not have considered in that palliative care environment. Next slide, please. Now, we often talk about planning ahead, and this is sometimes called advanced care planning. So if I give you the example of just me and my mum. So last year, when mum was becoming slower and a bit more forgetful, we talked about power of attorney, and I and my twin sister, we obtained legal power of attorney. We weren't, with my mum, she was never lacking in capacity, so we didn't really need to use it. But the idea was that if she got to a point in her life where she couldn't remember very well and she needed our help, we had the power to make decisions for her. So both medically, so, you know, I knew she didn't want to go into hospital. And so if she got to a stage where she couldn't speak for herself, I could say she does not want to go into hospital. but also financially, so that I could go to the bank and draw money out for her and pay her bills and those sort of things. And believe me, just doing that, it put all our minds at rest. I knew that my mum wouldn't have to worry about sending me off to get money out for her, or going and doing a shopping for her, or speaking to the doctor on her behalf. So that was legal power of attorney, and I printed off the forms, filled them out, got all of the representations I needed to. It didn't have to go through a solicitor. We did it ourselves, and it worked out marvellously. And I'm glad we did that. When we talk about advanced care planning, people shy away from it because they think, oh, this is me talking about what's going to happen at the end of my life. But we should do it when we've got our wits about us. When I worked in general practice, I had a lovely patient. She and her husband used to come in together. She was hilarious, and I sing in the choir, the hospice choir, and this lady used to sing with me in the choir, but she came to me as a patient. I always thought she and her husband had a great relationship. They were off on holiday here, there and everywhere. They were very fit. They didn't have any children. They had a great life. But she came in on her own one day, and she said she left her husband in the waiting room because she wanted it documenting that should anything happen to her and she got dementia and she couldn't speak for herself, she didn't want her husband to be involved in her care, because she said he was a selfish man and she knew he wouldn't care for her. And she wanted it documenting that she wanted to go in a care home where she would be cared for. Now, he didn't know that, but it was documented in her notes. And there is a sort of a legal process that you can go through so that your wishes are legally upheld. This was just her making her wishes known to me if anything happened in the future. But an example of planning ahead is the respect process. And this is where you discuss your wishes and document them in a recommended summary plan for emergency care and treatment. Now, sometimes people at the end of their life, they're asked about their respect form. And I know that sometimes it has upset people because it's been thrust upon them when they've become very, very ill, and it's almost like all their wishes have been taken away from them, and you know, we're not going to resuscitate you and want to discuss this and what's going to happen at the end, and it's extremely upsetting. And I don't like that approach, and I just think if you can think ahead and sit with your family and talk through your wishes, what you would like to happen at the end, even though it might be difficult for everybody, and you might shed a few tears and you might find it really difficult. It's much easier when you're strong and firm in your mind and you know what you want. So please take my advice personally and as a professional that that's the best approach. And when you go to the hospital, when you see a member of the palliative care team, they will mention it to you. But don't despair and think, right, well, this is the end of it. I'm now at that stage. Just think, well, we've already thought about this. It's so easy. It's all written down. There you go. We've planned ahead. We know what we want to happen. Next slide, please. So, as I say, the advanced decision to refuse treatment or the treatment that you want to take place can be a legal document. So some people will say, I do not want anybody putting tubes down my throat or leaping on my chest and resuscitating me. When nature has decided there's no point in carrying on, and I physically cannot carry on, this is what I want to happen. And so when these things are mentioned to you, don't think that this is because there isn't any hope or any further help for you. It's just that it's much easier to be done earlier. Next slide, please. So just going through a few of the myths and facts about palliative care. I need to look at my notes here because I can't actually see the screen. It seems to have shrunk a bit like me. I'm only 4'8", so if you can't see me, that's the reason. So first of all, people think that having palliative care means that they'll have to go to a hospice, and that's an absolute myth. You can receive palliative care, as I say, at home or in a hospital or in a hospice, or not at all if you decide you don't want any involvement in any with any specialists or professionals. Another myth is that if I have palliative care, it means my doctors have given up and I'll no longer receive active treatment for my illness. Again, you can receive palliative care alongside your treatment, such as chemotherapy and radiotherapy. So we would see people often in the hospice. They'll come in because they might have constipation and that needs to be treated, but they've got their chemotherapy or the radiotherapy this week. So they'll be sent out from the hospice in the hospice bus with a nurse to have their treatment and come back in the evening so we can carry on with their other treatment in the hospice. Having palliative care means I'm going to die soon. Well, palliative care can go on for years. And we have people who have chronic illnesses who we know there's no way of knowing what nature has decided. So the palliative care takes place alongside their illness and can go on for years, and we get to know people very, very well. But the palliative care is the specialist form of care. So, you know, managing their pain, managing the treatment of, I don't know, a stoma bag or tracheostomy, or all of those things that are associated with different types of illness and need a specialist to help direct that care. So it does not mean that you're going to die because you're having palliative care. And palliative care does not mean that you won't be seen by other specialists because they've handed it over, because often we'll work alongside an oncologist or a neurologist or a neurosurgeon or anybody that, you know, the respiratory physicians, anybody that you need as part of your overall care. Palliative care is just about treating pain and other physical symptoms. Well, no, palliative care can mean the psychological aspects of care. It's a holistic approach. So it's the anxiety associated with a chronic illness or a disease that you feel is progressive, and you need to have somebody else to lean on. Even as doctors, we need somebody else to lean on. And those people, they really do know how to speak to you and how to get to the nub of the matter. A doctor can speak to you in very sort of medical terms. A nurse can speak to you about the wound and the dressing. But people who deal in holistic care, who treat you from the whole person point of view, will see you as the person. And often we find that the other carers, the counsellors, even the art therapists, the creative therapists will know more about that person than we do because they confide in them. So please take up any offers of help from that point of view. And they're saying palliative care here isn't for family and friends. Well, it's for everybody involved in your care. So often we'll see the carers separately, because, you know, they may want to talk about worries that they have that they don't want the patient or their relative to know about. They may need a shoulder to cry on because they're having a difficult day, or they're not quite sure what words to use or how to deal with it themselves, or they just feel exhausted and they don't want to admit it. So it's for everybody. Palliative care is for everybody involved in a patient's care. Next slide, please. So please trust the experts, because we're here to help, and just take advantage of everything that is offered to you along the road. And with palliative care is just another area that you can turn to for help, alongside all of those amazing people, especially in Mesothelioma UK, who know far more than I do about the disease, but we're there just to help you along the way. Thank you.
Thank you. Thank you so much for sharing your expert knowledge and your insight, both professionally and personally there. There's already a number of comments coming in to say thank you for that. We're genuinely grateful, thank you. We're now going to go to another short comfort break, during which we're going to show the GEMS study animation video. The GEMS study was aimed at exploring the gender differences in patients with mesothelioma. And while you're getting a tea or coffee or a nip into the loo, we'll have this running in the background. We'll see you in 10 minutes. Thank you.
In the UK, over 2,500 people per year are diagnosed with mesothelioma. Exposure to asbestos is responsible for around 9 out of 10 mesothelioma cases. Mesothelioma is more common in men than in women, and nearly half of the people diagnosed with the disease are over 75 years old. The complexities of these gender differences, such as initial symptom development, experience of the diagnoses, occupational risk, and the extent to which patients seek legal advice and receive compensation, are less well understood. It's crucial for legal professionals, healthcare practitioners, and organisations that work with mesothelioma patients to understand these complexities and ensure that individuals get the support that they need. Research from the University of Sheffield, funded by Mesothelioma UK, has explored gender differences among people with mesothelioma in relation to time from symptom onset to diagnosis, seeking legal advice and receiving compensation, and occupational risk. The experienced research team pioneered the use of a large national data set and qualitative interviews to explore these complexities for the first time. Firstly, the research found that occupational risks were multifaceted. Exposure to asbestos at work was not only due to direct handling, but also indirect exposure like office blocks or schools. This broadens the range of occupations to be considered as high risk, from traditional occupations such as construction workers, usually associated with men, through to office workers and teachers, more commonly associated with women. As a result, when exploring potential mesothelioma risk, detailed occupational histories must be taken of patients by experienced professionals to consider a broader spectrum of direct and indirect risk. This links into the second key finding of the research. Diagnosis and subsequent care pathways varied across genders. It took longer for women to be diagnosed than men, and communication of the illness and risk between patients and healthcare professionals were influenced by gendered norms. Healthcare professionals need to consider a wider index of suspicion across occupations with direct and indirect exposure to asbestos to avoid gendered diagnoses and speed up diagnosis times. Equally, information provided to patients needs to be presented clearly and be sensitive to the needs and the priorities of the patient. Finally, the research found that women are less likely to seek benefits and compensation as a result of their condition, and if they do decide to begin this legal process, it takes longer than men to receive that compensation. This is impacted by gendered differences in family and social expectations. Relevant professionals need to improve information available to female claimants and signpost the help open to them. For more information on gendered differences in experiences of mesothelioma, read the report here. Reflect on your practice and consider how you could support patients more effectively, or refer patients to the Mesothelioma UK website and national helpline.
Welcome back, everyone. I hope you've got a nice cuppa and you're comfortable to see the rest of the afternoon with us. Really pleased to say thank you to Royds Withy King for sponsoring this session. And I'd like to introduce Caroline Twist. Carrie is 34, she's from Merseyside, and was diagnosed with peritoneal mesothelioma in June 2019, aged only 33. She had cytoreductive surgery and high-PEC chemotherapy in Basingstoke in November 2019, and is currently being monitored by a local oncology team in Manchester. Welcome, Carrie, over to you. Thank
you. Yeah, I'm Carrie, and what I wanted to do today was I wanted to tell you a little bit about my diagnosis, journey from diagnosis to treatment, and if we have time, tell you a little bit about the cytoreductive surgery from a patient point of view. So my diagnosis was a little unusual. So I basically went on holiday and my GP surgery refused my asthma medication. So I went in to complain and they said I had to see the GP. So while I was there, I sort of mentioned that I'd been having a couple of problems with my menstrual cycle and that I wasn't very regular. And I'd basically been having stomach pains, which I thought were unusual for me. So yeah, from there I got referred for a scan. So they just did ultrasound and they said, oh, it looks like you've got, so basically polycystic ovaries and maybe endometriosis. So I was referred to gynae and they did an external examination. They looked at the scan. They said, yeah, everything seems to point to endometriosis. So we're basically going to do a small up investigative. We're going to go in and see what the situation is. And if it is endometriosis, then maybe we can treat it then and then. So I waited about 4 months for this laparoscopy. And eventually it came around. I was first in surgery that morning. Everything went fine. And then when I was coming around, the doctor came to see me. And he basically said that they had found widespread nodules throughout my pelvis. They'd taken a biopsy, they'd sent it off, and I would know a bit more. So obviously I got home and you hear the words, sorry, biopsy and nodules, and you think, okay, I've got some form of cancer. I was 33, obviously really not expecting this, and what should have been a routine laparoscopy. But I waited for 3 weeks. Before I was due to get my results, they sent me for a CT scan. Still didn't really give me much information, and I went to see a gynae-oncologist. He basically told me they had no idea what it was, and that they were still waiting for the biopsy to come back, but they were going to refer me to a different hospital to see a specific consultant. So I went along for the appointment. Biopsy still not come back, and they told me that the first biopsy was inconclusive, so I would have to have another laparoscopy to take another sample. So at this point I was under St Mary's in Manchester, which is the women's hospital. So I had the second laparoscopy, waited another 3 weeks, and then they told me that they needed more time. So it was probably another five weeks before I heard back from my consultant. And he basically said that I had mesothelioma, peritoneal mesothelioma. At this point, I didn't know what mesothelioma was, which I think is very common to a lot of peritoneal patients, at least, if not a lot of mesothelioma patients. And yeah, he basically said that he thought it was low grade. He wanted a couple of weeks to work out some sort of treatment plan. And then I was invited back in to see what my options were. So he mentioned a number of options: surgery, chemotherapy or this watch and wait sort of strategy. And they went along with the watch and wait because at the time they thought I had a low malignancy form of mesothelioma. So we were going for the watch of wait. So off I go on holiday that August. And I come back to hear that my next appointment with my oncologist has been brought forward by 4 weeks, which is never a good sign. I usually put it back. Nothing ever good comes about having appointments brought forward. So basically I was told that my notes had been sent down to Basingstoke, which I already knew was going to happen, and that they had categorized me as high malignancy mesothelioma, not the low malignancy that I thought. Apart from being incredibly upset to hear that I had high malignancy, yeah, I had a lot of questions about why was the biopsy restudied and now was high malignancy, and lots of questions. I got an appointment to go down to Basingstoke where I met Sam and Mr. Mohammed, who were great. They answered all my questions. You've got to see a video of my liver and my stomach, which was not as gross as I thought it was going to be. And yeah, and from there, they invited me for a third laparoscopy to see what the situation was in my small bowel, about whether I would be suitable for HIPEC cytoreductive surgery and HIPEC chemotherapy. Luck would have it, I was. And so it was November 2019 that I went down to Basingstoke for the cytoreductive surgery. I'm not going to say anything too much on the medical side, but it was quite a big shock. I don't think I quite prepared myself mentally for the size of the surgery. Yeah, I think that it was a little bit of a shock. So I woke up in intensive care, and yeah, I didn't really feel great at all. The problem wasn't helped that my epidural had failed. So when you've just had abdominal surgery, the last thing you want is someone telling you you need to roll you onto your side while they change your epidural. And that happened twice. The first day in intensive care. So that wasn't the best experience of my life. Funny story about intensive care though is that the nurse that was looking after me in intensive care was great. She was really nice. And she said to me, "Oh, you're allergic to paracetamol and codeine. So when you take paracetamol, like what happens to you?" And I explained that my eyes swell, I break out in hives, and as soon as I said my eyes swell, she said to me, "You mean like now?" And I said to her, "What do you mean now? My eyes aren't swollen now." And now I think back, I think that my eyes probably were very swollen, and I just didn't even realize. I remember on the third day looking down at my hands, and my fingers were like 3 times the size that they were normally. And I was a little bit panicked. I said to the nurse, like, "What's happening to my hands? Like, they're so swollen." But I think it was because of the huge amount of anesthetic that I'd had. Well, that's what I'm putting it down to as well. Recovery in hospital was quite slow, but eventually after the 4 weeks, I managed to get home. I've heard a lot of other people who had much quicker recovery than me, so I think it was my dodgy stomach and the amount of vomiting that I had that probably didn't help. Another small funny story from my time in Basingstoke Hospital was that the first night that I went onto the ward with the other peritoneal patients in the hospital. So I was on a shared ward with me and one other lady, and the other lady asked for a Strepsil for her throat because her throat hurt so much. And I thought, oh, well, my throat really hurts as well. So I'm going to ask for the same thing. So the nurse came to me and she was like, yeah, you can have a Strepsil, but you have to promise me that you're not going to fall asleep because it can be really dangerous. Like it can get stuck in your throat and all that. I was like, yeah, I promise. I'm not going to fall asleep. And while you're awake, there's no chance that I'm going to fall asleep. Anyway, I nodded off, and about an hour later, I woke up and the Strepsil was stuck at the bottom of my mouth. So I had a spoon next to my bed, and I literally had to prise it off the roof of my mouth, and I put it back in my glass. And she came round a couple of hours later and said to me, "Oh, did the Strepsil not work for you?" And I was too embarrassed to tell her that I fell asleep. So I just sort of said, oh, like it did the job and I didn't need any more, but I never asked for another one after that. I was so terrified of falling asleep again. And yeah, as soon as I got home, my recovery was amazing. Within 6 weeks, I was back doing, no, it was longer than that, maybe 12 weeks, I was back doing yoga, back in the gym within 4 months. And since then, I've been doing really well, apart from the odd visit in hospital because of my liver, but that's another story, completely different story. And so sorry, I've just rushed you through in 10 minutes the whole of the last 3 years of my life, but there we go. And now I want to introduce Sam, who is the peritoneal nurse in Basingstoke that looks after all of us peritoneal patients so well. So I met Sam back in September 2019, although we had spoken on the phone before that. And since my surgery, we speak quite often, and we've been on various calls with Mesothelioma UK together. And so I'm really proud to present Sam to everybody.
Thank you, Carrie, for sharing your inspirational story with us. My name is Sam Westbrook, and I'm a peritoneal mesothelioma specialist nurse. I work at Basingstoke Hospital in Surrey, and my role is funded by Mesothelioma UK. Today, I'm going to give you a brief overview on the UK statistics, clinical presentation, how peritoneal mesothelioma is diagnosed, treatment pathways, and patient support. Next slide. Next slide again, please. In 2020, the Royal College of Physicians published the National Mesothelioma Order Report. This was for a period of 2016 to 2018. This showed 7,000 patients were diagnosed during this period, and peritoneal accounted for 260. So that's 130 cases per year. And this demonstrates its rarity. The audit also showed a positive outcome of doubling of referrals to the National Mesothelioma Peritoneal MDT compared to the previous audit. Peritoneal mesothelioma has a more favourable prognosis compared to other mesotheliomas, but it does depend and vary depending on several factors such as cell type and stage of disease. Next slide, please. The peritoneum is the lining of our abdomen. There are two layers. The visceral layer, which is next to the abdominal organs, shown in blue on the diagram, and the parietal layer, which lines the abdomen wall, in orange on the diagram. If asbestos fibres become lodged in the peritoneum, it can lead to irritation, and the damaged cells develop into tumours. These can cause symptoms. The peritoneum becomes thickened, and fluid can collect in the abdomen. This collection of fluid is known as ascites and causes the abdomen to swell. The disease spreads across the abdomen, rarely spreading to other areas of the body. Next slide, please. Diagnosis of peritoneal mesothelioma is often delayed because of non-specific symptoms, such as abdominal pain and abdominal swelling. Commonly, symptoms include ascites, change in bowel habits that are not normal for the patient, such as constipation or diarrhea, lumps in their tummy that they can feel, bowel obstructions, hernias, and the more cancer-specific symptoms such as weight loss, fatigue, and loss of appetite. Next slide, please. Diagnosis involves a series of tests and usually starts with scans and x-rays. These tend to rule out other more common cancers first. CT is useful in diagnosing and can report the extent of the disease. PET and MRI scans are also used, but they're yet to show superiority over CT in assessing the small bowel. Biopsy is the recommended method to diagnose peritoneal mesothelioma, and this can be done at the time of diagnosis, so diagnostic laparoscopy. This is where a surgeon will assess the volume of disease, identify whether there is small bowel involvement. Laparoscopy is used to determine whether a surgical approach can be achieved as a treatment option. Using an ultrasound to aspirate the fluid from the tummy is often carried out, but it does have limited diagnostic potential, so it's not really recommended. Peritoneal mesothelioma. Next slide, please. Peritoneal mesothelioma is treated with a variety of approaches. It's recommended that all cases are referred to the National Peritoneal Mesothelioma MDT. For some, the option of surveillance or watch and wait may be adopted. This might be for patient choice or those with a more low-grade cell type. Surgery is available for eligible patients. We know this as CRS and HIPEC, cytoreductive surgery with hypothermic intraperitoneal chemotherapy. It attempts to improve the prognosis, combining aggressive surgery and intraoperative chemotherapy. The surgery aims to remove all visible tumours and tissue damaged by the mesothelioma cells. The HIPEC is applied to the abdominal cavity during the surgery to kill any remaining cancer cells. In advanced peritoneal mesothelioma, treatments include chemotherapy and immunotherapy, aiming to improve patients' quality of life and extend their life expectancy. Clinical trials are conducted to study new therapies and methods of treating peritoneal mesothelioma. There is a new downloadable app called Mesothelioma Clinical Trials, where patients and healthcare professionals can view the available current trials in the UK. Next slide, please. Patients referred to the peritoneal mesothelioma MDT at Basingstoke are contacted to offer support. Often these discussions on the telephone are focused around discussing their diagnosis and treatment pathways, or signposting them to local patient support services. The referral process also involves the MDT offering advice and information to the referring team. Next slide, please. The last few years have seen patient support for peritoneal mesothelioma greatly developed. Offering a point of contact with a peritoneal mesothelioma nurse opens the door for patients to gain as much support as they would like. This might be for information gathering, discussing treatment options, discussing clinical trials, locating support in their area that they live in, as well as those listed in my slide here. The wider support offered by Mesothelioma UK offers webinars for the patients to log in and listen to. There's an information line where there's a nurse always available at the end to talk to, and the website with lots of patient educational booklets and pages on. Next slide, please. The past year has seen the virtual platforms embraced. A virtual support group was set up for patients to meet others with the same disease. Stories are shared of personal experiences, and it offers a place of friendship and support for the patients. For those that are less inclined to use the virtual platform, a buddy support service was set up. Patients with similar experiences are connected together on a one-to-one basis. Next slide, please. I hope you found this very brief talk helpful and informative. If you have any questions, please ask at the end of this session at the live Q&A. My email address is attached here if you would like to contact me directly. Thank you.
Thank you, Sam and Carrie. So encouraging to hear about the development of peritoneal services. Certainly when I first started to work in mesothelioma, no services existed. So it's so encouraging to see the development that's happening in this area. To conclude the last part of this particular part of the session, I'd like to welcome Mr. Fahiz Mohammed. Mr. Mohammed has been the Clinical Director at the Department of Surgery and Neurology at Hampshire Hospitals Foundation Trust since 2017. His clinical interests include colonoscopy, laparoscopic surgery and treatment of advanced colorectal and other peritoneal cancers with cytoreductive surgery and HIPEC. I do need to warn you that during this talk, there will be graphic images of scenes of surgery. So if you'd rather not watch it, then please be aware that there will be scenes on camera. Thank you.
Hello, my name's Fahiz Mohammed. I'm a consultant surgeon at the Peritoneal Malignancy Institute in Basingstoke. Thank you for the opportunity to talk to you about our experience with the National Peritoneal Mesothelioma MDT and cytoreductive surgery and hypothermic peritoneal chemotherapy for peritoneal mesothelioma. So peritoneal mesothelioma is rare. Nobody's quite sure what the incidence is, but it's probably around 1 in 5 million people. It's the most common cancer affecting the peritoneum. And there are a number of people who have both pleural and peritoneal mesothelioma, probably 10 to 30% of those who present with mesothelioma. Median survival is not very long from diagnosis. It can be around about a year on average. The response rate from systemic chemotherapy is pretty poor, around about 30%, and there haven't really been any new drugs over the last 2 decades, with most people being treated with the standard couplet that's used for pleural mesothelioma. There's no clear definition of the natural history of peritoneal mesothelioma. Most people run into trouble because of progressive disease causing compression of the organs within the abdomen. We're beginning to understand more about the histology. There is a spectrum ranging from malignant peritoneal mesothelioma, such as epithelioid, to less aggressive types, such as multicystic peritoneal mesothelioma. It's becoming increasingly clear that surgery in selected patients is the most effective way of managing the disease, and combined with hypothermic intraperitoneal chemotherapy, we can get good long-term results. People have also used early post-operative intraperitoneal chemotherapy, so given into the peritoneal cavity at room temperature immediately after surgery, as well as longer-term intraperitoneal chemotherapy using indwelling catheters and repeated administrations. More recently, pressurized intraperitoneal aerosol chemotherapy, or PIPAC, has been used for patients who have disease that's widespread and not suitable for the cytoreductive surgery. The mode of presentation for patients with peritoneal mesothelioma isn't always straightforward. Many present with increased abdominal distension, abdominal pain, or loss of weight, and these are fairly non-specific symptoms, so it can take some time to come to a diagnosis. WHO have classified peritoneal mesothelioma into the most common type, which is epithelioid, then sarcomatoid, and biphasic, which is a mixture of the two. On the other end of the spectrum are well-differentiated papillary mesothelioma and multicystic peritoneal mesothelioma. Epithelioid mesothelioma tends to affect men, mainly in the 5th and 6th decades. There is an association between prior asbestos exposure, and disease can often be widespread, involving the small bowel surfaces. You can see this middle picture is a patient with disease involving the omentum, but also the serosa of the small bowel. And in this case, we were not able to remove all the disease. We can get some clues from preoperative imaging, but often it's only at the time of surgery that things become obvious. Sarcomatoid mesothelioma is rapidly progressive and tends to have a poor prognosis. There are some patients who do respond to systemic anti-cancer treatment, and they may benefit from surgery. Biphasic mesothelioma is a mixture of epithelioid and sarcomatoid. Again, success from surgery is very much dependent on whether patients can respond to systemic chemotherapy or not. Moving to the other end of the spectrum, well-differentiated papillary mesothelioma is often slow-growing. Patients can have extensive disease, but it can be present for many, many years before people become symptomatic. Cystic mesothelioma, again, can become symptomatic because of the volume of disease. You can see that picture in the middle of someone with widespread cystic mesothelioma that was causing symptoms from abdominal distension, but also pressure on the stomach and the bowel, stopping people from being able to eat and drink. So what is the evidence to support the type of surgery that we do in Basingstoke? We know that if we can remove all visible disease by stripping the peritoneum and removing any organs involved with tumour, combining this with a hot chemotherapy wash, we can achieve good long-term outcomes when compared to systemic chemotherapy alone. This is pooled data from centres that treat peritoneal mesothelioma, 401 patients from centres around the world. You can see here the median survival is 53 months, and the 5-year survival is just under 50%. So half of people who've had a complete tumour removal are alive at 5 years, which is much better than chemotherapy alone. People have tried to predict those patients who are likely to benefit the most from surgery, and you can use complicated statistics to try and identify those characteristics that mean people benefit. One such paper suggests that patients with low volume epithelioid mesothelioma who have low tumour markers are likely to get the most benefit. If you have sarcomatoid or biphasic mesothelioma, then you're less likely to benefit from surgery. Recently, centres from around the world have devised practice guidelines for the diagnosis, treatment and follow-up of patients with peritoneal mesothelioma, looking at the characteristics such as tumour markers, the Ki-67 expression, which the pathologists can tell us about, as well as the extent of disease as indicators for long-term outcome. We know that laparoscopy can be helpful to establish whether we can achieve a complete cytoreduction, because CT scans and MRIs don't tell us the whole picture. Our own experience in Basingstoke was published a few years ago. This is 76 patients with mesothelioma and a mix of multicystic as well as epithelioid, and a few patients with biphasic and well-differentiated papillary mesothelioma. We see these patients in clinic and spend an hour with them with our specialist nurse. CT scan is still the mainstay of imaging. tumour markers, CA125, CEA and CA199 are useful tumour markers to give us an idea of how the disease might be progressing. If we want to assess suitability for cytoreductive surgery and HIPEC, we laparoscope patients to look primarily at the small bowel and whether the surfaces are involved, as this is what usually stops us from achieving a complete cytoreduction. The curve on the left, the line at the top, are those patients who have cystic mesothelioma, and those are the patients who have the best outcomes after surgery. We know that when we use the hot chemotherapy wash, the chances of the disease recurring is reduced significantly. And we've published that data again recently. Historically, these cysts were scooped out and they'd almost always recur. But we now find that the rate of recurrence is reduced if we use the hot chemotherapy wash or the HIPEC. At the moment, we are the only centre in the United Kingdom that treats peritoneal mesothelioma surgically. Some of you will know that NHS England does not routinely fund this treatment. And so we decided back in 2015 to streamline the process, and we run once a month a national peritoneal mesothelioma MDT with centres from Birmingham, Manchester, Dundee and Dublin, discussing cases that have been referred. On average, we're discussing between 15 to 20 cases a month. The majority of those patients are not suitable for surgery, as it's not uncommon for people to present quite late on in their disease. But we identify those that we can help, and then we see them in Basingstoke and often laparoscope them before offering them surgery. You can see that the numbers of referrals have gone up steadily since we started the mesothelioma MDT. You'll have heard from Sam, who is the world's first dedicated specialist nurse for peritoneal mesothelioma, and she's allowed us to really strengthen our service, providing significant support for patients with mesothelioma from around the UK. An exciting development on the horizon is pressurized intraperitoneal aerosol chemotherapy. So this is for patients who have widespread disease that's not suitable for the type of surgery that we do, but who are having symptoms. And there is evidence to suggest that giving this chemotherapy basically under pressure, using an injector pump that pushes the chemotherapy into the abdomen and creates a fine mist or an aerosol, which promotes penetration of the chemotherapy into the tumour cells, can downstage disease and have a significant impact on symptoms such as ascites. The French are running a trial where they're randomising patients with peritoneal mesothelioma to a combination of PIPAC and systemic chemotherapy versus systemic chemotherapy alone. And they're following patients up by CT and laparoscopy to see what effect it has on the disease. We have been able to purchase the kits to perform PIPAC in Basingstoke with the generous help and support of Mesothelioma UK, HASAG and the Mavis Nye Foundation. We're hoping to set things up soon. We're delayed a little bit by COVID, and we plan to follow a similar protocol to the French. So what have we learned? We know that epithelioid or cystic mesothelioma tend to have the best outcomes. The less disease there is, the more likely we are to be able to remove it, and the more successful surgery will be. Women tend to have a better overall outcome with peritoneal mesothelioma than men, and those people who have no lymph node involvement also tend to do better. Future developments, immunotherapy has had a remarkable impact on our treatment of and management of peritoneal mesothelioma as well as pleural mesothelioma. There are new molecular markers on the horizon which will allow us to select patients more effectively. I think there's a lot of work to be done around the use of intraperitoneal chemotherapy as well as PIPAC, and I'm hopeful that we'll be able to help more patients in the future. Thank you.
Thank you. Thanks so much for staying with us this afternoon. What a wonderful afternoon we've had with such informative speakers. I'm delighted to be joined again by Carrie and Barbara for our question and answer panel session. Welcome, Carrie and Barbara. Thanks so much for your presentations today. They were so informative, and I know from the comments that we've had coming in, they've been so well received. A couple of things to point out is some real words of thanks for yourself, Barbara, in sharing your personal journey, your personal story with us today, and just how important it is to have those conversations. A comment that we had about being able to talk about and focus on the practical things and organise what might need to happen in the future. For example, you know, maybe a husband who does all the bills and does all the practical things in the house, and making sure that's all talked about and prepared for. I think one thing I wanted to ask you was about how people might start those tender conversations, because these are things that we, as you said, we all should be thinking about and talking about as early as possible, but we have a tendency not to. So what would be your advice for starting those tender conversations between people?
Well, often we leave these conversations until somebody has had bad news, and then it feels as though, well, this is an awful conversation and one I don't want to have, and I can't bear the thought of it. So I do think if you can have those conversations even now, if you haven't got any diagnosis, but the best way really to talk about it is we have to be strong, and we have to be sensible and pragmatic. And sometimes, especially when I'm seeing patients for the first time, say in the hospice, and I say to them, I'm going to have a conversation with you now, and we have the same conversation with everybody. I'm not singling you out. It's not frightening. It just will help you in the future. So if, as a family, somebody takes the lead and just says, look, we've got this diagnosis now. It may be years and years and years ahead, but let's just get everything in place now, right now, so that we don't have to talk about this again. And not just for the person with the diagnosis, but for the carers as well. So I'm, for example, going to sort out power of attorney for my twin sister, because my husband died some years ago and I'm on my own. I don't know what will happen to me in the future. I don't have any children. Somebody has to be in a position to take over if I become unwell. I'm being sensible. I'm going to ask my sister to have power of attorney for my affairs. So I think without the emotion attached to it, without it being a miserable conversation, let's be sensible and pragmatic, and let's just deal with it like we're dealing with the scan when it comes. Get through it. It's another obstacle. We've had the scan. We'll get the result. We'll move on to the next bit. That's the way I would deal with it.
Thank you, Barbara. That's great advice. Great advice for all of us, really, isn't it? And if I could come to you, Carrie, this was a question that was actually posted for Nigel, but I did want to ask you as well because it's very relevant for you. So, you know, as being diagnosed with mesothelioma so young, is there anything that you would do differently, and what advice would you give to other people who are diagnosed young?
Would I do anything differently? I don't really know. I mean, all through the diagnosis, I sort of felt I had to hold everything together. And then actually after my surgery, I struggled quite a lot with anxiety, and after numerous appointments with a psychologist, I guess that if I could have sought the help from a counsellor earlier, then that may have helped in terms of the mental health of, you know, problems that come with having a diagnosis so young. Yeah, I think that would be something that I would like to have done before. I think that would be very helpful.
I'm not sure if we've lost the sound here. Ethan?
Go. Apologies, we are having a few technical hitches here, but we're going to go back to the comments and the questions. So as Leah started to talk about, lots of positive comments from this afternoon's sessions. There was one question about the what are the best Facebook groups to join, because I think Nigel mentioned them, and they are an invaluable source of support. Mesothelioma UK have a Facebook group, and there are also lots of patient groups on Facebook as well. So you can try any of those, really. If you do want any advice about what group to join, do ring our information line on 0800 2409, because we would be able to find out what exactly you wanted from the group and be able to guide you from there. But all in all, really, it's been very positive comments about the sessions this afternoon. I would like to perhaps hand over to Liz to close the day, and just to say thank you to everybody, to all our sponsors, and This bit of the session is sponsored by Lee Day. Liz.
Thank you so much, Anne. I just want to apologise to everybody. We had a few technical hiccups there with our chairs losing network and having to drop off the call, and then Anne Lesser stepping in at the last minute. So apologies for that. So what an amazing day. So for those of you who don't know me, my name's Liz Darlison. I'm the Chief Executive of Mesothelioma UK, but I'm also a nurse consultant working at the University Hospitals of Leicester. And I've pretty much managed to remain on the whole of the event today, and I applaud absolutely everybody. It's been fabulous. I think Nigel and Carrie, it's always just so amazing to have a patient's perspective, and we thank you so much for being so candid and open and honest. I just wanted to, I haven't prepared any slides. I'm going to finish up with just chatting to you really, a little bit about where we've come from, what we've achieved over the last couple of years, and what our priorities are going to be going forward. So we've been around now for 16 and a half years, and for the first 4 years we were a Macmillan Cancer Support Service, 4 or 5 years really. So we launched the charity 12 and a half years ago, and it was 10 years ago that we actually managed to appoint our second nurse. So we've had quite a steep journey of growth really as a charity. So we are now at 35 nurses, which is pretty phenomenal, and each of them are passionate, dedicated and really expert in mesothelioma and committed to doing all they can to support patients, families, colleagues, trying to do their best, and of course making our NHS as best we possibly can for people living with mesothelioma. We couldn't support those nurses without our partners, and I want to just do a particular shout out for HASAG, Asbestos Action Tayside, Action on Asbestos, the Mavis Nye Foundation, and our legal partners who all financially have supported the nursing posts that we support through the charity. We also have 2 benefits advisors. We have Caroline in the main office and Sarah up in the northeast, and we are also delighted to work closely with Lisa at HASAG, who specialises in our armed forces advice. We have just appointed the 15th member of our operational team. They're not all whole-time equivalents, so it's not 15 whole-time equivalents, but we are delighted to welcome Abby, who joined Mesothelioma UK Ops team just this week. She's an apprentice, and there's been a really warm welcome for her, and we hope that we will help her start out on her career in business administration. We've developed a robust approach to the governance of the charity. We rely on our public advisory group for that purpose. We have a clinical expert group as well, with representatives from all 4 nations and every discipline involved in the treatment and care of people with mesothelioma. We're grateful to our ambassadors who represent us across the country and fly the flag for the charity. And of course, we couldn't be anywhere without our trustees, who give up an enormous amount of their time and also show an awful lot of passion for what we do. We meet with the trustees monthly. We probably have 1 or 2 months a year that we miss, but generally speaking, it's a monthly meeting, so it's quite a big time commitment. And you know, they all really do immerse themselves in the charity and the vision for what we look to achieve. We outsource some of our services, so all of our IT services are outsourced, and you know, Technical Solutions are one of the companies that we outsource to, and also our comms and media. I just want to do a shout out for Sandstar, who provide our comms and media support. So suffice to say, it has been a really difficult 18 months. Some of our nurses were redeployed to work in COVID areas. I think it's fair to say that some of our nurses were really anxious and scared. You know, a lot of us, it's been a long time since we've worked in a ward environment, and that would be scary enough, having to go back to a ward environment and all the new systems, processes and technology. But to do that in the middle of a pandemic when every healthcare professional was pretty scared, you know, frightened about what we're taking home, frightened about contracting diseases ourselves. Some of our nurses have been ill since their redeployment, physically, emotionally, and some have just felt a bit close to the wire, a bit burnt out with it all. We all work in the NHS and we're all really dedicated to the NHS. So putting, you know, the personal impact on the nurses for being NHS employees, I think the one thing I would say that they have managed to achieve through the last 18 months is their commitment to their patients, even if they've been hived off to work in intensive care, or, you know, some of our nurses ended up manning communication hubs, which were responsible for breaking bad news to family members because there was no visiting and so on. They've still managed to remain committed to their patients throughout and tried to do everything they can to minimise the level of disruption to people's cancer treatment and care. The nurses have been very active advocating at a local level to try and maintain services, support and treatment for mesothelioma patients. And on a national level, we've also linked with a number of other charities and worked really hard to keep beating the drum for cancer services, to make sure that we feed back directly to the people making the decisions at the top of the NHS about the impact COVID has had on people living with mesothelioma. And I want to thank everybody who completed the surveys that we circulated last year regarding the COVID pandemic. That information, that intelligence that provided us was invaluable for feeding back. You know, anecdote and hearsay doesn't really cut it in those kind of settings. We have to have it from the horse's mouth. We have to have really quality intelligence from the people that are being affected to be able to feed that back. Lorraine and the nursing team have worked really hard as well over the last 18 months to keep our community together, and I would say actually to make it stronger and a tighter community. We've had to rely on the virtual platforms for that. There's been the Facebook live sessions, the webinars that we run now once a month, the many interviews, and please do catch up on those. There's been some amazing interviews with some really inspirational people. There was the launch of the carers group, the younger patients group as well. Sam's managed to keep the peritoneal group going. And then I have to say, of course, there's Simon, who has taken over running our regular quizzes, and Be There or Be Square, our next quiz is on the 28th of October in the evening. So look out on our social media for that. You'd be made very welcome. It's always a bit of a giggle, and Simon never disappoints with his outfits. So what else have we achieved apart from keeping things afloat and addressing all of the challenges that the COVID pandemic brought for us? Well, we've survived the COVID pandemic so far as an organisation. We've had to adapt hugely, and I think that we've done an amazing job in helping the mesothelioma community to stay together, not on our own obviously, but I think we've complemented and contributed to keeping that community together. We've managed to secure, thank you to everybody that has supported us, we've managed to secure adequate income over the last 18 months. As I said, we're quite a young charity. We've had an incremental growth year on year over the last 10 years since we launched as a charity. And we haven't seen that growth, obviously, over the last 2 years, but we've managed, we've got a great finance team, and with some really careful management, we've managed to complete the service developments that we had in the pipeline, and managed to secure enough income to keep everything ticking over as we'd hoped to. The nurses' numbers have grown, as you've seen, and we have got more of the UK covered, which is a huge success. We've relaunched the website and we've had some fabulous feedback. Please do have a walk through our website, and we'd love to hear your feedback. It's there for you, and so your feedback is more important to us than anything. We recently appointed an information manager. Joelle joined the team a few months ago in order to be recognised as a provider of information within the NHS. There is quite a rigorous accreditation process, and so there should be. You know, I think we have to be sure that the information patients are being given is credible, referenced, evidence-based information. And the process to achieve that is quite a you could say quite a grueling one. And so it was essential really that we brought somebody into the team who has the expertise to do that and can focus on it. And so we have managed to recruit somebody. Joelle has joined us, and she's systematically going through all of our information sources to make sure that we're up to scratch with our accreditation, and also to develop our information resources. So if you've got any comments about information, we're really glad to hear those as well. We are looking forward to an office move. This has been in the pipeline now for 18 months. I think it was May 2020 that the site was secured for Mesothelioma UK. We're very grateful to a private donor who is making this all happen for us. And we are looking to move into our purpose renovated, I suppose, not purpose built, purpose renovated offices at the end of this month, beginning of November. And it will be just great to have the space. We'll be able to be all under one roof, because even prior to COVID, we were in 3 offices side by side, but we'll all be under one roof. And to actually be in the same building will be a huge benefit to the operational team. You heard earlier from Claire Gardner, one of the co-directors of the Mesothelioma UK Research Centre in Sheffield. And obviously the research centre was in the pipeline for some time. We managed to go ahead with that. We're absolutely delighted. There's been a huge amount of evidence and publications that have emerged from that team. And we are extremely excited about the future of that collaboration with Sheffield University. And I have to give a big hands up for the research team, because they are a pretty special group of people, and we have developed a wonderful working relationship with them. Again, always opportunities for people to get involved. Just contact Meso UK or the research centre. But again, I have to keep reminding everybody, all of this is to help anybody and everybody affected by meso, and we need you involved as much as you're possibly able to. We also launched our first independent research grants earlier this year. The peer review process is nearing an end, I understand, and I think we're going to be awarding those grants very soon. And we have funded about £1 million worth of research in the past, but this is the first time we've done it independently and peer reviewed the applicants ourselves. And we had a really healthy number of applicants. And Sam Morgan has coordinated that on the charity's behalf. Lynn Ferber got us on track. I want to say thank you to them, but also to David Hetmansky and the research and audit group that organised all of that. Another huge achievement this year was we were voted the Health Service Journal Armed Forces Team of the Year. That's a very prestigious award to be given. We were up against some stiff competition. We didn't think we were going to clinch it, but we did. I'd like to thank Mira from our comms team, Manisha, from our comms team, who coordinated that whole application. It was pretty special. And I have to say, please do have a look at the MIMES report and our Armed Forces section on our website. We were funded through the Covenant Fund for this work, and it came from the nurses being concerned about the number of armed forces and veterans they were seeing with mesothelioma, and we felt, again, anecdote and just our experience is not enough to make a difference at that level. We had to have rigorous evidence to demonstrate that this is a problem, it is an issue. And so we embarked on a 4-year project, a whole range of work streams involved in that, and the research was a core part of that. And the MOD, Health and Safety team, have said that single-handedly, Mesothelioma UK and the research team have held the MOD to account for the exposure of service personnel to asbestos and then to go on to develop mesothelioma. So do have a look at that, and it was just wonderful for all of that work to be recognised, winning the Health Service Journal Armed Forces Award. We, with the help of Sam Morgan, who joined the team a year ago, we have managed to embark on a rigorous kind of program of campaigning and kind of lobbying, I guess. But again, I just consider this to be advocacy. This is just doing everything we can to stand up for people with mesothelioma. And we've joined in, supported or initiated a number of different campaigns. We have been pleased to work with Asbestos in Schools and DUAC to support the issue of the amount of asbestos in our schools and the impact that is having. We were pleased to work with Res Publica, who have an asbestos, an Airtight on Asbestos campaign that has been running for about the last year now, looking at the management of asbestos in situ in the UK and how that falls woefully short of how it should be managed. And when you compare us to other countries in Europe, our standards are just simply not good enough. We've worked very closely with the armed forces community over the last 4 years, which has been a whole new experience for us. We've also supported Action Mesothelioma Day and worked with the UK Mesothelioma Coalition. Some of you will be aware of the MAG study, the Mesothelioma Awareness Guidelines study that was dedicated to Mags Portman, a young doctor who sadly lost her life to mesothelioma. And we made a pact with Mags that we would do all that we could to raise awareness about the number of healthcare workers being affected by mesothelioma. And again, another piece of research carried out by our research team that really has shone a light on the impact of asbestos and mesothelioma in healthcare workers. And we are still working hard to maximise the impact of that. And we'd love to see mandatory asbestos awareness for all healthcare workers so that they're aware of the presence of asbestos in hospitals and that there is no safe level of asbestos. We've also been working with, you've heard today from Andrew Payton from the Asbestos Smart initiative. Again, patients always say, don't let this happen to anyone else. You know, we feel it is very much part of our role to do all we can to protect the next generation and every generation to come from asbestos exposure. And the UK National Asbestos Register is just one really smart way to chip away at that. So please remember, if you think you know anybody who is responsible for maintaining buildings, please do remember the Asbestos Smart initiative and signpost them to it. We've worked really closely with Cancer 52 to campaign on a number of issues related to a lot about the COVID pandemic and trying to get the messages right and trying to make sure that cancer services continued in clinical trials and so on. And we've also embarked on our own little campaign to try and raise the profile of home treatment within the NHS. For any patients that were having treatment privately during the pandemic, you will know that your treatment was not interrupted in the same way that patients who needed to attend hospital was. And what we've tried to do is to just raise the profile of the possibility of home treatment within the NHS, particularly for more vulnerable patients. So all in all, you can see that it's been, you know, a pretty busy year since we last had the Patient and Carer Day. And, you know, every time you think that you're just getting to complete one task and you think that things might, you know, the workload might just ease up, there's a whole new load of opportunities comes around the corner that we just can't resist. And so we, you know, we really do take on board everything that we possibly can and take up every opportunity we can to further anything that will help people with mesothelioma. So for the future, Faye and the ops team have been working really hard to develop the charity's infrastructure. You know, it's like running any organisation. You've got to have the nuts and bolts and the cogs and the wheels all in the right place and all lined up. Otherwise, it'll all fall to bits. And that takes time to make that happen. And Faye has been absolutely amazing at pulling all of that together and putting in the right policies, procedure and governance in the background so that we can be absolutely certain that we are safeguarding the longevity and the future of Mesothelioma UK. We're looking forward to our office move. It's a bit like, it almost feels like, you know, we've had a fairy godmother sprinkle fairy dust for us. And please look out for the opening of that office. There'll be lots on social media. We'll be thanking our private donor and all of the contractors many who have given their time free of charge to revamp those offices for us. We're looking to increase our nurse numbers, of course. Particularly Northern Ireland, Wales. Sarah Morgan's been working really hard to try and replicate what Carolyn and Kevin and the team in Scotland have achieved. We're also trying to talk to hospitals in London to try and get new centres in London and just generally plug the gaps. We're looking to award a tender contract for the national audit, and I think it will be a year at least before we can get a report out for the national audit again. We're going to be launching the health companion that you saw earlier. Lots of emphasis on the support groups, as always. Our patient information and website, as I said, is going to be continually revamped, and we're going to maximise the benefit of that. We're 110% behind the UK National Asbestos Register, and then all the campaigning that I mentioned, that also will continue. And of course, not least, income. So our income streams have changed quite significantly. We really do need to focus on legacies, grants, and also getting an army of volunteers. If anybody is interested in volunteering to help the charity in any way, shape or form, but particularly with our fundraising, then please do get in touch with the charity. Big thank you to our partners, as I said earlier, the Meso UK Ops team and our contractors, all of the nurses. I'd like to say, Anne, Carolyn and Leah, you've done an amazing job today. Thank you so much. Our legal panel, you're always there for us. Many of you have been sponsors today: Slater Gordon, Owen Mitchell, Novum Law, Field Fisher, Hugh James, Thompson, Royd Withy King and Lee Day. Big thank you to all the speakers, Technical Solutions for pulling it all together in the background. Rachel, Owen, our events person, massive deal pulling this off. Well done. You've done a fabulous job. And with that, I would just like to say to all of you, please stay well, keep in contact with us, and we look forward to speaking to you, hearing from you anytime you choose. Take care, everybody.
Katie, if you're still there, say thank you.